Hello and good afternoon. I must start by thanking Jamaica Cancer. Hello and good afternoon. I must start by thanking Jamaica Cancer Society to this wonderful colon cancer medical symposium. I'm going to talk about gut microbiome and the link with cancer. Hello and good afternoon.
Sorry about the switching.
Do you have, why am I echoing? Do you have, oh, we have the phone open.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing. Healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxybeta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
Good morning.
Good morning. Can you hear me?
Yes, I can. I'll be with you in a minute. Yes, if I can't hear you, I will be with you shortly.
Yeah, do you want me to test the sharing screen?
Hi, Prof. Good morning.
Morning. Do you want me
I'll
to
be with you in 1 minute, please.
No worries.
Okay. Hi. Hi again, Prof. Good morning.
Hi, morning again.
Okay.
All good with you?
So far, so far.
Good.
So you can
do
go
you
ahead.
want me to test sharing the screen for a second?
Yes, for a second, but not for too long. Just share and stop share because we have a live feed to YouTube. However, I'm the only one looking.
No, I saw that. And also, when my turn comes to speak, I will, of course, share the screen again. And but when I finish my talk, do you want me to stop sharing or you take control and stop sharing?
No, I'd like you to stop sharing, please.
Okay, I will stop sharing myself. That
Thank
is
you.
fine. And I'm just going to test my share screen now to make sure it is all good.
No problem.
So that is my share screen. That's my presentation mode.
Yes, I can
And
see
that
it.
is my advance and that is my going back. Looks all
Excellent.
good to me.
It
So
looks good.
I will stop share now.
Okay, great.
And so what I'm going to do is I'm going to stay on the link because it is the same link as the actual meeting. Yeah.
Yeah, yes, it is, Prof. Please do stay.
Yeah. So I don't have to come out of it and join a separate link. I just stay on this link. I will keep my video off and I will keep my microphone muted till I am required.
Excellent. Thank you
I'm
so much
just
for
confirming that I am the fourth speaker. So once the third speaker finishes, I will start getting ready.
excellent. Plus, I have your number.
That is
Okay.
true.
Right.
Yeah.
Okay.
Feel free to have a chat with me anytime.
All right, Prof. No problem. So I'll
Okay,
catch you.
I'm just going to go off the video now.
Sure. So I'll see you later.
And I'm going to mute my microphone as well, and I will stay in the background.
Okay, Prof. Bye.
Lovely. Thanks a lot.
Yep. See you. Good morning, Dr. Mills. Welcome.
Morning, everyone. Thanks. Appreciate that. Everyone okay?
So far, thank you. And I hope the same is on your end.
Yes. There's a scheduled power outage in the Mona Hope Pastures area in about half an hour, but I don't know if it will affect this location. So let's see.
Let's see.
Yes, indeed.
All right, later.
Amen.
Good morning, Dr. Murphy, and welcome.
Good morning. How are you this morning?
Pretty good, thank you.
So just confirming, my background looks the same as what you're going to play today?
I'm sorry, say that again?
The background that I'm using looks the same as the recorded version, so that when you play the recorded, it looks like I'm doing this?
It looks similar.
The lighting is okay?
Let's talk by telephone,
Okay.
because I'm also streaming live to YouTube. Yes, sir. Good morning again. Oh, thank you. Hi, Mr. Leslie, welcome.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
Good morning and welcome to the 12th staging of the Jamaica Cancer Society Colon Cancer Medical Symposium. My name is Shulian Brown. I'm the Fundraising and Public Relations Officer of the Jamaica Cancer Society. Welcome to you all. I'm sure it's going to be an informative session. We have our guest speakers, Dr. Gosh from Ireland, and Dr. Floyd Carter from the Bahamas. Welcome to you all for supporting the Jamaica Cancer Society, and we look forward to having you support our other activities for the year. Our moderator this morning is Dr. Mike Mills, gastroenterologist and assistant professor at the University of the West Indies. Doc, I'm getting old. So thank you all. Going over to Dr. Mills now. Please begin.
Thank you very much, Julian. Thank you for the Cancer Society for allowing me to moderate this symposium today. Good morning, everyone, and thank you for joining us for another symposium in our annual series. The panel that has been put together this year is stellar as per usual. And as Julian mentioned, we do have a number of collaborations from our overseas contributors. They are all connected, not just because we're speaking about a common topic of colorectal cancer, but I will leave it up to you to pay attention to the talks and to the intros to see just how our panelists are all connected in some way. I would like to begin by acknowledging our sponsors, Facey Pharmaceutical, Abbott, AA Lakis, and Apex Radiology. Of course, we would not be able to host our symposium without the assistance of some of our sponsors, and also look forward to the support being provided by our technical team behind the scenes to make this symposium successful. So the topic for today is colorectal cancer, and we have a number of different aspects that we're going to focus on. We're going to begin by inviting our first speaker, Dr. Trevor Murphy, to come to the podium to speak to us today on an important aspect of colorectal cancer. Dr. Murphy is no stranger to us in Jamaica. He is affiliated with the University Hospital of the West Indies and also in his private capacity at the Island Medical Specialist Practice in Kingston. He's a consultant gastroenterology and the current division head of gastroenterology at the University Hospital of the West Indies in Mona, Jamaica. His area of subspecialization in gastroenterology is that of therapeutic endoscopy. And he is a graduate of the MBBS DM program at the University of the West Indies, Mona, and also did his GI fellowship at McMaster University in Hamilton, Canada. He is also the current president of the Association of West Indian Gastroenterologists. And it gives me great pleasure to invite Trevor to speak to us this morning in his capacity of a specialist with responsibility for identifying and managing patients with colorectal cancer regarding the signs and symptoms of colon cancer. Dr. Murphy, please, you may begin.
Good morning, everyone. Would like to thank the Jamaica Cancer Society and Dr. Mills for inviting me to give the first of these sessions this morning on colorectal cancer and the various aspects of colon cancer. Now, you may feel that signs and symptoms of colon cancer is not a particularly exciting topic to be discussing on Sunday morning, but the reality is that colon cancer screening signs and symptoms is a marker for how well we are actually doing with our colon cancer screening programs. So as per, I guess, my normal thrust in doing these presentations, I would like to change the topic just a little bit, and we'll make it sort of prevention of colon cancer screening. So let's move on to our objectives today. We're going to look at a few things. Number one, we'll look at colon cancer just in general. I will ensure that we're defining what signs and symptoms actually are. We'll look at the important signs and symptoms as they relate to colon cancer, and why we shouldn't really wait until signs and symptoms develop before we start any kind of screening program for colon cancer. So colon cancer itself, in terms of the definition, is relatively straightforward. It is a cancer that develops in the colon and the rectum. We know that they are a continuous tube, and although there are some definite nuances between sections of the tube, and even within colon and rectum, the cancer, this neoplastic entity is determined basically as a single entity. So in an ideal world, we would try to minimize a discussion about signs and symptoms of colon cancer. Why is that? Well, theoretically, colon cancer is one of those cancers that might, in fact, be quite preventable. Now, why would I say that? Well, it is defined as a relatively slow process from benign to malignant. It has a relatively easily identifiable precursor lesion. And there are also available therapeutic interventions that can prevent the progression of colon cancer. We know that most colon cancers develop through the sequence of, from an adenoma to an adenocarcinoma. And this all gives us an opportunity before the signs and symptoms are present to prevent the cancer by removing its precursor lesions. And this also allows us to identify colon cancer at its earliest and sometimes curable stages. Recognize that approximately 70% of these colon cancers develop from adenomatous polyps, which is like a little mushroom that grows off of the lining of the bowel, and that the remaining of them probably go through a different pathway, which is a bit more complex, but is often called the serrated polyp pathway, which involves sessile serrated lesions. And this is where colon cancer originates from. And if we can remove these, by identifying them before symptoms occur, this will give us the best outcome. The reality is that we still need, in some way, to understand the signs and symptoms of colon cancer, because no matter what screening program we put together, no matter how vigorously we try to engage people in a screening program, there are always going to be people who are either too young or too old to engage in a screening program. And they may, in fact, present with signs and symptoms, which we must recognize. If we look at the Jamaican data from 2020, you can recognize that colon and rectal cancer is number 3 behind prostate and breast, accounting for about approximately 11% of the number of new cases of cancer in the country for the year. In the world, if we took a more global view, colon cancer is the second most common deadly cancer. So it has the second highest mortality rate, but it is actually the 3rd most commonly diagnosed cancer overall. Our northern neighbors in the United States ranks colorectal cancer as the 2nd cancer in terms of mortality, only behind lung, and 3rd, again, most commonly occurring cancer in both men and women. Closer to home, if we look in our own backyard, we see that colon cancer itself is the 3rd leading cause of cancer-related death in Jamaica. And if you were to just tease into our 2018 data, you would recognize that almost 60% of people who are diagnosed with colon cancer die from their colon cancer. So we're clearly picking them up later than we need to. And why is there so much colon cancer? Well, the reality is that the colon is a tube, and it's a relatively capacious tube. It has quite a lot of inner space. And these signs and symptoms occur late in the course of the illness and may often or frequently be misinterpreted as other conditions such as hemorrhoids, fissures, or some other cause of discomfort or a sign relating to the colon. And we miss that this, in fact, may be a neoplastic lesion. So therefore, our colon cancer, or colon cancer in general, worldwide, is often picked up a little bit too late, and it becomes difficult to cure and a burden in terms of treatment and expense. Let's take one step back and just make sure that we're on the same page. So what is a symptom? Well, a symptom is something that someone describes to you. It's a physical or mental problem that a patient experiences, and we cannot quantify it objectively. So something like abdominal discomfort. A sign, however, is something that is a little bit more objective. It's something seen during a physical exam, a laboratory test, or an imaging study. So we are able to see or define something a little bit better. And that's what kind of we're speaking about today. There are many different attempts worldwide to determine the signs and symptoms of colon cancer with lots of advertising and lots of nice graphics. But the reality is that a lot of these signs and symptoms occur late in the disease process and make the disease a challenging one to treat and manage. So let's look at some of the signs and symptoms of colon cancer. Again, just from my sort of a theoretical standpoint, if your colon is like a hose and things travel within it from the right side to the left side, the colon cancer that we're dealing with here is growing on the inside of that hose. If we were to just cross-section the colonic wall or even the rectal wall, you'd notice that most of the excitement when it comes to colon cancer occurs at the level of the mucosa. So it is relatively easy to see, and it is relatively confined initially at least to the superficial layer of that layer cake that makes up your bowel. So the colon, as the colorectal cancer grows within the lumen of this tube, it'll have anatomical effects, it'll have functional effects, which just have to do with where the mass or the growth is. And then you have associated effects outside of the bowel itself. Symptoms, again, things that are described to us, things that people feel, can vary depending on where the problem is in this length of tube that we're speaking of, in the colon and the rectum. There are various types of abdominal pain that are described. They typically are not very well described initially because, as I mentioned before, the colon has quite a lot of space inside of it. And as these mass lesions are growing, they may cause no symptoms, and as they progress, you get more symptoms. And then as the patient gets more into the disease in terms of the stage of the disease, they will become more defined in terms of where the lesion is causing these problems. So it may become more evident that it's on the right side versus the left side to the patient. Unfortunately, some of them present with this ubiquitous reference to gas, which is often very difficult to define. But in reality, it's a part of the package that we must deal with. If the mass lesion is involving the rectum, which is a very functional aspect of the colon and rectal system, this is when we start seeing or we start hearing the patients describing things like a sensation of incomplete rectal evacuation, which we formally call tenesmus. And this is the brain's attempt or a bad interpretation of a lesion inside the rectum, which to the brain feels like the person has some stool in there, but it's not luminal content at all. It's actually the mucosal wall stimulating the nerves. If you were to take basically a mass lesion and place that mass lesion anywhere along the colonic and the rectal length, a person may be able to describe that they have a fullness in that area. And again, although it's relatively difficult for them to do so initially, as the mass grows, they may be better at localizing where this mass may be and feel a fullness in a particular area. You can see that if there's a transverse colonic mass, the person may actually have very dyspeptic-like symptoms. And this is often a problem because it's thought of to be something else entirely. One of the signs of colon cancer that people love to speak of is the bleeding aspect. Now, as I just alluded to, the tube is relatively long. Your colon varies in length from the size of your genetic tree. And depending on where the lesion is, if it is bleeding, that may cause a difference in the way the person presents in terms of their bleeding. So right-sided colonic tumors can be completely asymptomatic, and in most cases they actually are. If they've been there for long enough, they may cause occult blood loss, which can be picked up on screening tests. They may present with what you hear about as anemia. So the patient has a relatively normal stool, but there is blood in the stool when you test it. Or if the blood is at a reasonable rate, they may be producing a dark blood. Why is it darker? Well, the blood is being put into the lumen of the colon, and the colon is full of bacteria. Your microbiome is an essential part of your digestive system, and this denatures and alters the blood appearance. As the lesion moves more distally in the colon onto the right side, so if the person has a colorectal cancer on the left side of their bowel, then because it has less contact time within the lumen of the colon or the rectum, we would suspect that the blood would be brighter, and that is in fact what we see. So a brighter red blood does typically mean a left-sided lesion, and a darker blood does typically mean more contact time with the colon and can speak to a more proximal colonic lesion. But unfortunately, this is not always the case. Outside of the colon itself, signs and symptoms can be borne out by the effect of either blood loss or some other factor on the typical target organs that a person has. And those typical target organs are the brain, the heart. So one may see, because of lack of blood, because of anemia, that the person presents with non-specific, not really related to the colon cancer itself directly, but as a secondary effect, such as stroke. We often hear about dizziness or weakness generally. Some people may have true syncope. They may have chest pain if they have heart disease, hypotension, postural weakness, and then again, the sign and symptom of anemia. So the signs and symptoms of colon cancer and rectal cancer in general are quite varied. And again, just to reiterate them, some of the signs, things that we can actually see are bleeding per rectum, blood in the stool in this case, a mass possibly felt in the area of the colonic distribution, iron deficiency, anemia, weight loss, or an abdominal mass. Again, symptoms, something is described to us, a myriad of different types of pain, from very minimal pain to cramping pain, depending on the stage of the actual lesion itself. The ubiquitous reference to gas, which to me, after many years of practicing, I'm still not really sure what that means. But a change in bowel habit is also present in some people and is an important symptom. Incomplete bowel evacuation speaks to more maybe a left side lesion involving the rectum, and then general weakness and fatigue. If we sort of try to look at signs and symptoms of colorectal cancer from an objective manner, an evidence-based manner, there's a relatively recent publication out of a Norwegian group, which did a fairly good job at looking at this. It's probably one of the largest objective measures of colon cancer and the presence or absence of symptoms that we have so far in our dearth of literature on colon cancer in general. It actually looked at almost over 42,000 patients, of which they subjected these patients to either sigmoidoscopy or a fecal test. So the FIT test looking for blood in the stool. And if we look at just sort of the data, because the numbers are quite large, it fell in line with all the smaller studies that we had. So I just draw your attention to this chart. And if we look at the FIT test, which essentially is the blood test, so it's an immunochemical test looking for blood in the stool. And then the sigmoidoscopy obviously is a telescope test, but a shorter version of a colonoscopy. The most important thing about this particular chart is what's in red. So they looked at colon cancer, and they also looked at advanced adenomas in patients that had symptoms with a myriad of symptoms outlined, varying from change in bowel habit to abdominal pain to various other things. And I would invite you to read the article if you're interested in it, because it's fairly well outlined. But the reality is that if we look at colon cancers, whether they were picked up by a stool test or by sigmoidoscopy, 60% of those patients actually had no symptoms at all. They were asymptomatic, and they were just included in the study. Again, it was a randomized study, so it enabled the comparison between these two populations. Again, if we look at the way in which colon cancer develops, which is through the adenoma sequence in most cases, we see that almost 3/4 of these patients had an advanced adenoma and were actually asymptomatic. So just to be clear, what does an advanced adenoma mean? So an adenoma is that mushroom that grows on the lining of the bowel. An advanced adenoma must have certain features, but basically it's a larger adenoma in terms of size, greater than 1 centimeter, and it has an architecture to it. So when the histopathologist looks at it, it will have some advancement, some maturity, some movement towards dysplasia in it. And this is an important marker of a polyp that is moving towards colon cancer. So again, just to look at the numbers, very simply, 6 out of 10 diagnosed with colon cancer in this particular study were asymptomatic, and 3 out of every 4 who had an advanced adenoma diagnosed were also asymptomatic. In the same article, if we tease through the symptoms, we say, well, if symptoms are actually present, which remember, in the majority they're not, rectal bleeding was the one that was very important. So rectal bleeding was strongly associated with the detection of colorectal cancer and an advanced adenoma. And I guess the most meaningful way to look at these is an odds ratio. So if an odds ratio is exceeding 1, therefore there is a positive correlation between a particular entity and developing something, an outcome. And in this case, colorectal cancer had an odds ratio of 4.3, which is clearly greater than 1. And advanced adenoma was just slightly over that, but because it's a relatively exponential increase, 1.8 is a significant figure. And because the confidence intervals are relatively small, we know that these are significant. But having said that, and again, maybe a little difficult to understand sometimes because it took me a while to kind of wrap my head around this, rectal bleeding still had a very small positive predictive value, which is really only 1.9%. Why is this? So if this has a very high odds ratio for colon cancer and a reasonably high ratio for advanced adenoma, why is it that rectal bleeding has a positive predictive value that is so low? In other words, 98% of patients had rectal bleeding from some other source, which is actually what we see. So when you say some other source, well, the people that had rectal bleeding, the bleeding was not from a colon cancer. It was from hemorrhoids, a fissure, or some other mucosal abnormality. So that's an important indicator. That's an important concept to understand. Bearing in mind again that 60% of people in this particular study, and this is congruent with literature, who have diagnosed colon cancer were asymptomatic of it, and 75% of advanced adenomas were also asymptomatic. This is not a new finding, but it definitely gives more power because the N number for the study was quite large. The second symptom that is actually important again, if the symptoms are present, is change in bowel habit, which really was helpful in the detection of colon cancer only and not adenomas. And the odds ratio in that one was 3.8, which is quite high. So again, if present, a useful symptom. If not present, not a useful symptom. If we look at the sort of the last part of this, the presentation today, and speak about survival curves or Kaplan-Meier curves. This is a little bit older paper, about 4 years ago, again, published in BMJ, but it looks at the survival of asymptomatic people and symptomatic people who had colon cancer and how they presented. And we can see that there's a significant difference in the survival of people who presented with asymptomatic versus symptomatic disease, suggesting again that symptomatic disease does worse overall, it presents later overall, and their overall outcome is significantly worse. Again, a significant hazard ratio in this particular case of 3.42. So you are 3 times, almost 4 times more likely to not survive your colon cancer if you presented with symptoms. So in summary, and sort of in closing and prevention of signs and symptoms today, please don't wait for signs and symptoms to screen for colon cancer. Remember, precancerous polyps often don't cause symptoms, and removing them can prevent colon cancer. Therefore, we remember that 3 out of every 4 patients who had advanced adenomas were asymptomatic. And early colon cancer does not always present with symptoms. In fact, it often doesn't present with symptoms. So and remember, in the paper from the Norwegian group, 6 out of every 10 patients were asymptomatic. Colon cancers found in people without symptoms are not as advanced and more frequently cured. The detection of colon cancer at an early stage obviously increases your cure and survival, and we can see the survival curves are very, very well described. And because most colon cancers and advanced adenomas are asymptomatic, screening is the most important part, and screening, as you will hear from many of the other people who are speaking today, is based on various criteria. If the signs and symptoms are present, we need to know that rectal bleeding is one of them that is a significant sign of colon and rectal cancer, and that change in bowel habit may also speak to colon and rectal cancer. So the new moniker for American College of Gastroenterology this year is 45 is the new 50. And I hope that all of you will engage in some sort of a screening program, not only for your patients, but also for yourselves. And I would be very happy to take any questions now regarding the signs and symptoms of colon cancer and prevention of colon cancer. Thank you very much.
Thank you very much, Dr. Murphy, for a very clear presentation and an interesting approach to the discussion of signs and symptoms. I'm going to ask everyone to address their questions in the Q&A section, which is located at the bottom of your Zoom screen. So we'd encourage you to address all questions in that aspect, and then we will read them out and take them as they come. Perhaps I'm going to start by asking the first question. So, Dr. Murphy, can you just maybe give us your approach to individuals who seem to present with signs and symptoms of colorectal cancer? From a patient standpoint, especially those patients who present very frequently, having had investigations recently, but still are convinced that they have signs and symptoms suggesting colon cancer. How do you approach these types of patients?
I think it's a good question, Mike. GI in general is very age-based, so our guidelines are very age-based in terms of how we approach the patients. I think what you're alluding to is one of the biggest problems that in the younger cohort that we see generally, a lot of the symptoms and not so much the signs, but more the symptoms that are associated with colon cancer in general, colorectal cancer, there's a huge overlap between them and people that have functional bowel disorders, so irritable bowel syndrome. And I think that it's important that There's a proactive diagnosis in the younger patient. In other words, we do the sort of basic blood tests, looking at their CBC and their ESR after, of course, we've taken the history from them and gotten their symptoms. But in the older group would be a bit more aggressive. And in this group, unfortunately, from the American college standpoint, old now is 45. So a lot of us are north of 45 these days. But the reality is that you have to be a bit more aggressive. And it depends on the patient. I think that any screening test is better than no screening test, first of all. So I think that's very important because patient compliance is critical. So if a patient is more reluctant to have a physical intubation test like a sigmoidoscopy or a colonoscopy, then we need to definitely try to engage them in doing something that they're comfortable with, which is a fecal immunochemical test or something of that nature, at least so that we get some idea that they don't have a problem which we need to deal with. But I think it has to be kind of patient-centered. I know there are quite a number of patients who are not really that comfortable submitting themselves off the bat to a telescope test, essentially a colon cancer test. So that would kind of be my response to that. There's a huge menu of things we can do in terms of colon cancer screening. And just finding one that the patient at the particular age is comfortable with, I think, is the most important thing.
What point do you become comfortable that you've adequately investigated a patient who continues to complain of symptoms, gas, for example?
Yeah. I like to take a patient-centered approach. So depending on the person, and you have to kind of gauge each and every patient. You have to find their comfort level. My comfort level obviously is luminal. I like to make sure that they actually don't have colon cancer with a colonoscopy. But in a younger patient, that's actually a relatively invasive step for them. So looking at their basic inflammatory mediators, ESR, C-reactive protein, their blood count, that gives you a very high index of suspicion of something bad there or not. But if they do have hard signs, maybe rectal bleeding or a significant change in their bowel habit, a luminal test is probably the way to go. It can be radiological. It doesn't have to be a physical intubation. But to me, I really try to do a patient-centered approach when it comes to screening for luminal disease, because the patient has to invest and understand why you need to do certain things with them, but they also have to be comfortable with the test. And each test has its own little caveat. So I think that's kind of the way I would still go about it, is looking more at the patient than actually what we physically have available to them, or sort of enforcing something on them that they're not comfortable with.
All right, thank you very much. I do see one question in the Q&A at the moment. It is discussing FIT test compared to colonoscopy as a screening tool. I'm going to ask you to just hang on, don't answer that question yet. I do know we have a talk on colon cancer screening, including the use of colonoscopy and whether or not that is best, and that will be coming up with Dr. Carter. So I'm just going to ask our attendee who's asking that question, just hold on. If it's not addressed in that talk, then we'll certainly address it and mention it again at that time. So if you have any other questions, please feel free to enter them in the chat. Okay, so I'm not seeing any particular questions at the moment. So I'd just like to thank you again, Dr. Murphy, for, oh, hang on. There is a question here, 1 second. What screening method would be recommended for someone who's younger and is believed to be having symptoms? Okay, yes, please go ahead and address that question.
So again, kind of spinning back and what we were speaking about before.
Sure.
Again, depending on what symptoms they're having, because the functional bowel disorders, there's a huge overlap between functional bowel disorders, which typically present around, just after adolescent stages, and bad luminal disease. So the first thing we do with patients who are much younger, a very thorough history is very important for a younger person, because you need to try to tease out what their symptoms really are. And then you do a basic panel on them. So if you take the approach of a functional bowel disorder, it's supposed to be a proactive diagnosis. And that proactive diagnosis is brought about by their positive history, number one, and then looking at their complete blood count, their ESR, C-reactive protein. And if it's a diarrhea predominant kind of functional bowel disorder, then you look at their thyroid. If all of those are normal, then there is evidence that a watch and wait sort of protocol is in order at that point. If the person, again, has a very personality that will not allow them to function properly, then you may want to do some sort of luminal study. And the luminal study can be radiological, or it could be an intubation study like a colonoscopy at that point. But again, it's a layered approach to them. You don't have to go straight for a more invasive test in a younger person who has symptoms, depending on what the symptoms are.
Okay, and thank you very much for that question. There's another question here in
Screening
the chat. Oh, at what age we stop screening?
Again, that's
okay. So
it's not really for me to answer, so I'm going to hold on.
Right, I'm going to hold on to it, definitely. We will get back to that question.
For sure.
Please feel free to go ahead.
Very good question.
Yes, post all the questions, no problem. If we think that they can wait for another talk, we will go ahead and just note them and have them answered at some point before the end of the symposium. If there are, how available is a fit test? You did mention the fit test, Trevor. So someone is asking about the availability of the fit test in our Jamaican population.
So fit test is not incredibly available in Jamaica. It's a form of FOB test. I can stand corrected. The private labs are in the second generation, I believe, of FOB testing. So fit test is not readily available here, unfortunately. Mike is definitely shaking his head because he's concurring with that. It is an unfortunate aspect of our screening protocols. We're still kind of on a little bit lower generation FOBs here, but they're still better than nothing. If you're looking at sort of a second generation going into, a bit more technologically advanced test, I guess, the second generation still gives you around a 66% pickup rate, which is double what the first generation was. So it's still a test that's better than nothing, but because the second generation tests are not based strictly on human globin chains, they require dietary modification and that kind of thing. So the fecal immunochemical test, if available, would be a much better option. And it is worldwide more accepted than kind of what we're using here. So that is it's an excellent question, actually.
Okay, thank you very much. Any of us post that? We do have maybe another minute or so. Again, I'd like to thank our sponsors for allowing us to put this symposium on today: Basie Pharmaceutical, Abbott, AA Lakees, and Apex Radiology. I did indicate earlier that all our speakers are connected in some way, so I'm still encouraging you to pay attention to the profiles and pay attention to the talks and see if you can decipher how they are all connected. So I'm not seeing any other questions at the moment. So again, thank you very much, Trevor, for this talk this morning. And if you can stick around, please do so.
Absolutely.
We'll definitely love to have your input where necessary.
Okay. Thank you. Thank you, everybody. Have a great day.
Oh, hang on. There is a question. Don't disappear yet, Trevor. I do see another question. Thanks. So concerning the symptoms of pain, which quadrant of the abdomen is the pain most experienced, or how does it vary? Does the pain have a specific characteristic? And concerning the subjective symptoms of gas, can it be related to bloating? Can it cause the abdomen to be distended? Wow.
So that's another symposium all in itself. When are we having that one? Okay, it's a lot of big layered question there. I'm going to leave bloating alone because bloating, most people don't define bloating in the way GI defines bloating. So I'm going to sort of leave that one alone for now, and I'd be happy to discuss it off the air if you want to. But the reality is that GI pain, GI luminal pain, is very difficult. And the reason for that is because it's a tube. And depending on the stage of the problem actually is predictive of the type of pain the person will have. So their pain initially is relatively vague and poorly localized. And that's actually what makes colon cancer quite difficult to sort of clue into in the beginning. Because it's a tube, it's a functional tube, and it has a myenteric plexus, which is very well established. The typical pain can actually be almost like a function, like a cramping type of pain that only comes about when the bowel itself is stimulated. But when the lesion, the cancer, grows and starts to involve other areas, different layers of the bowel, and becomes a bit more tethered, then the pain character will change. And that's when it becomes a little bit more persistent, constant, and well localized. But that is, again, suggestive that there's an invasion of the surrounding structures. And that's not the kind of pain that is predictive of a good outcome generally. So again, just to sort of summarize that very wordy answer, it tends to start off very poorly localized, tends to be a bit more crampy. Usually they can localize the side. That's not usually a big problem, but the pain changes in character over time as the actual physical lesion grows and expands and involves other structures.
Okay, thank you very much. I do see mentioned in the chat here that Biomedical will bring in the fit test. The patient prepays from a Dr. Claudia Walter. So yes, we do know that if you pay for it, in Jamaica, you can get pretty much anything.
It's true. That's very true.
Thank you very much for that input.
Yes.
Okay, if there are any burning questions, we can definitely accommodate that. You can type it in the chat and Dr. Murphy will be quite happy to reply in the chat. But thank you once again very much, Dr. Murphy, for your talk this morning.
All right, thanks again.
Okay, so we're going to move on to our second speaker today. And our second speaker is also at University Hospital of the West Indies. It's Dr. Rory Thompson. He comes to us with his post of being a lecturer and consultant pathologist in GI and liver pathology in particular. He's a graduate of the MBBS and DM programs at University in Jamaica, and did his fellowship training in GI pathology at the University of Toronto in Canada. He does have special interests outside of medicine, including a cornucopia of sports-related activities. And it gives me great pleasure to invite Dr. Thompson this morning to speak to us about colon polyps. Are they all the same? Dr. Thompson.
Good morning, everyone. Good morning, everyone. I would like to thank the Jamaica Cancer Society for asking me to speak to you guys today. My name is Rory Thompson. I'm a lecturer in the Department of Pathology at UWI. And today I'd like to speak to you about colonic polyps and whether or not they're all the same. I have absolutely no financial disclosures or any conflicts of interest at this time. So what are my objectives today? So today we're just going to look at the definition for what makes a colonic polyp a polyp. And then we're going to look at the more common epithelial polyps. We're going to separate them into two big groups, or neoplastic or pre-malignant or adenomatous polyps, and our non-neoplastic polyps. And after looking at our adenomatous polyps, we're going to look at what are the worrisome features that you can see in and around these neoplastic polyps that make us a little bit more wary for colorectal cancer or progression to colorectal cancer. And I'd like to start off by just going over a little introduction from an index case that we got in 2018. So this case came across my desk, and it was a history that was given to us that she was a 43-year-old woman that had some bright red blood PR and some mucus with her stool. And she was referred to her clinician because of this for scoping. She was given the routine prep. She went in, and when they popped the lower GI endoscope in, they saw so many polyps that they stopped and eventually aborted the procedure. She went on to get her upper GI endoscopy done, not with the same scope, with a separate scope. And again, they saw a lot of polypoid masses all over her stomach, completely obscuring the normal lining. She was subsequently set to have CT scans done to make sure that she doesn't have any disease elsewhere. And then she was referred to the surgeons. So when someone goes and has a total colectomy done, this is the specimen that we would get in the Department of Pathology. So this is showing the colon from the serosal aspect all the way from the cecum to the rectum. And all this fat that you're looking at, this is just this fat that's there, that's just where it brings all the support structures in towards the colon. So it's this mesocolonic fat. So what happens is that this colon is usually submitted in a bucket that's filled with 10% neutral buffered formalin. And the amount of formalin is usually around about 10 or 15 times to 1. This hardly ever happens. So when we get these specimens, we have to cut them open, which allows for the mucosa to be fixed. And a majority of these lesions arise from the mucosa. So what you're looking at now is fixed mucosa after formalin has impregnated the open specimen. After this, we will take sections, and these sections would be processed and subsequently stained. And this is what we would see underneath the microscope to represent the entire bowel wall. So the empty space up the top, that's the bowel lumen where the feces would be, but that's all completely washed away. Subjacent to this is your mucosa, and the mucosa is made up of our crypts, which are lined by our epithelial cells, and our lamina propria, which contains our inflammatory cells. The mucosa lies on top of the muscularis mucosae, which kind of holds everything in place. Subjacent to the muscularis mucosae is the submucosa, and the submucosa contains neurovascular structures and loose connective tissue, and this is what brings out the nutrition to the mucosa of the bowel itself. Subjacent to the submucosa are our smooth muscle bundles, or inner and outer layer, called the muscularis propria, and betwixt the muscularis propria fibers is your Auerbach's plexus, which is necessary for peristalsis, or movement of that of the feces from one end, the cecum, all the way down to the rectum and anus. Subjacent to this was the yellow tissue that you were looking at, which is your subserosal tissues forming your mesocolonic fat. Before we progress, we just have to just remind ourselves of a couple of these definitions. And according to the Merriam-Webster 22, the online dictionary, a polyp is a simple polyp, is just a growth projecting from a mucous membrane. So you guys remember that. We have to cover things such as a hamartoma, because we're going to talk about our non-neoplastic polyps. And what are hamartomas? They're just a benign proliferation of showing an abnormal mixture of normal cells that should be found in that area of the body. They're just arranged abnormally. Dysplasia is always a hard one to define, but it's a term used to describe abnormal cells within a tissue or organ. Dysplasia is not cancer, but it does have the ability, if it goes unchecked, to become cancer. For colon, dysplasia is separated into two groups, and dysplasia is usually seen in an adenoma. And it's based on what we see underneath the microscope as pathologists. So we have two groups. We have low-grade dysplasia, which is mild dysplasia or moderate dysplasia, and we have high-grade dysplasia, which is severe dysplasia. In a low-grade dysplasia, it looks more like normal colon, but in high-grade dysplasia, it looks very ugly and starts to look more like cancer. Which brings us to colorectal cancer. What exactly is colorectal cancer? It's just abnormal proliferation of these epithelial cells, and they just get dysplastic and they grow out of control. They grow through the bowel wall and subsequently extend to involve other tissues. Colonic polyps can arise from any layer of the bowel wall, but today we'll be focusing on colonic epithelial polyps. And these epithelial polyps are always luminal mucosal projections, and they can be either pedunculated or sessile. The pedunculated polyps are the ones that are disposed on a stalk, and the sessile ones are the flat ones that have no apparent stalk. So our colonic epithelial polyps are separated into two big groups, the non-neoplastic and the neoplastic/adenomatous group. So we're going to take the non-neoplastic group first. The non-neoplastic group, number one, inflammatory polyps. So inflammatory polyps are common polyps that they tend to be seen a lot in conditions such as inflammatory bowel disease. And you will learn a lot about inflammatory bowel disease today because Dr. Dawkins, towards the end of the day, will be speaking about IBD and colon cancer. But for this talk, we have to now think about inflammatory bowel disease. And inflammatory bowel disease is separated into two big groups, ulcerative colitis and Crohn's. They share similar pathogenesis, where the body is seeing the normal mucosa of the bowel as an invading antigen. Basically, it's seeing it as viral cells, and then it's just mounting a response to these viral infected mucosal cells. And that's where the inflammatory polyps are usually seen in IBD. You tend to have a lot of plasma cells and lymphocytes inside the lamina propria, splaying the normal cryptal structures. You not only see inflammatory polyps in IBD, you see them in patients who don't have IBD, such as in patients who have chronic constipation and may have things like a mucosal prolapse syndrome. So these mucosal prolapse syndromes, the most common form you will see is what's called a solitary rectal ulcer. So this solitary rectal ulcer usually occurs in the sigmoid or rectum, and what you have is this hard, tough, impacted stool that's compressing the mucosa, leading to contact ulceration, and towards the edges of this ulcer, you will have proliferation of your smooth muscle and inflammatory cells, resulting in the formation of an inflammatory polyp. We can see inflammatory polyps in patients who have chronic infections in the bowel, and we can also see them especially around the mouth of diverticular outpouchings in the colon of patients. So this is a photomicrograph showing you an inflammatory polyp, typically of one seen in inflammatory bowel disease. In the upper right-hand side, I have a little snippet showing you the normal colonic mucosa. So in an inflammatory polyp typically seen in IBD, you will see marked expansion of the lamina propria by inflammatory cells with splaying of the normal colonic crypts. And these crypts, for the most part, are almost always devoid of dysplastic or neoplastic change. The other common non-neoplastic colonic polyp are hyperplastic polyps. And these hyperplastic polyps tend to be seen round about age 50 when screening starts in the Caucasian population, and they tend to be seen in the rectum and the sigmoid areas. These polyps are usually very small, around about 5 millimeters, and they tend to look like little pimples, that they're a little raised, but they're not pedunculated. So the photomicrograph on the right is showing you how us as pathologists, how we view hyperplastic polyps. So this is showing the most common one. This is called a microvesicular hyperplastic polyp. The microvesicularization is because of small vesicles of mucin that's actually stuck within the cytoplasm of the lining epithelial cells. It tends to be seen along the luminal aspect, and they extend 3/4 way down the crypt, and then they abruptly stop. And then towards the base of the crypt, it's usually normal and mature, where you can start to see that kind of sawtooth type appearance that they tend to describe in these hyperplastic polyps. These hyperplastic polyps tend not to have any dysplastic change. In fact, they don't have dysplastic change in a majority, 99% of the patients that they present in. A lot of patients can have hyperplastic polyps, and they are not precursors for malignant lesions unless you have a hyperplastic polyposis syndrome. So the other non-neoplastic colonic polyps that we have to touch on are the hamartomatous polyps. Remember the haphazard arrangement of normal structures that should be there. And the two types are Peutz-Jeghers polyps and juvenile polyps. So most of these Peutz-Jeghers polyps, some people believe that there are no Peutz-Jeghers polyp outside of Peutz-Jeghers syndrome. There are a couple of papers out there that have persons who have a solitary Peutz-Jeghers polyp alone, but it's been called into question as of recent years. So Peutz-Jeghers syndrome, you actually have a mutation in your serine threonine kinase gene. And this kinase gene is necessary for polarization of the cells, which actually tells the cells that everything is fine and you should shut down and you don't have to make another copy of yourself. However, when you lose this gene, you end up having rapid growth and division of these cells. And this rapid growth and division occurs all over the body, which allows for Peutz-Jeghers persons or Peutz-Jeghers patients to have an increased risk for cancer in their pancreas, their stomach, and specialized tumors that you tend to get in your testicles and ovaries. So in the Peutz-Jeghers syndrome, a lot of these patients, it's not the polyps that allow for their diagnosis. It's because they tend to have this mucocutaneous hyperpigmentation in their genital region, their palms, and around their mouth. A lot of these Peutz-Jeghers polyps, you tend to see them more inside your small intestine than your colon. And a lot of these patients who do have these polyps, they tend to present with intussusception. And the reason why these polyps, they tend to have interception is that when you take a look at the histology of these polyps, so the picture on your left is showing the endoscopic picture, and the picture on your right is showing what we see underneath the microscope. What the colonoscopist is seeing is that this person has this kind of weird bosselated polyp, could be looking like a tuberculous adenoma. But what we see is just a proliferation of benign epithelium with relatively normal amounts of lamina propria, but you have these arborizing smooth muscle bundles kind of septating the lesion, giving like a banyan tree type appearance. And that is prototypic for a Peutz polyp. Given the amount of smooth muscle that's there, it's tethered to the bowel wall. So every time you have a peristaltic kind of movement, every time you have contraction, you will have this Peutz polyp continue pulling the mucosa until it telescopes into itself, and hence the patients tend to present with intussusception. Juvenile polyps, this is what we tend to see a lot of when it comes to hamartomatous polyps in Jamaica. And when you have these polyps, the story is always the same. This is when mommy is looking at the baby and the young baby is trying to poop, and eventually the baby poops and everything is fine. But when mommy goes and she checks the diaper or she checks the pampers, she sees the little ball surrounded by mucin, and she panics and she runs and she brings the baby in and says something is wrong. Your job at this point in time is to look, evaluate that polyp or that mucus ball, and just explain to her that if this is the first time this is happening, if this baby is less than 2 years old or this infant is less than 2 years old, don't panic. You put that thing in formalin, you send it to the pathologist so we can take a look at it and make sure that it is indeed a juvenile polyp. Most of the patients who have juvenile polyps, they're all sporadic. And we have a couple syndromic families here, but they tend to have juvenile polyps later on in life, usually as teenagers or adults. They tend to have multiple polyps, usually more than 3, and they tend to all have a family history of either colonic or gastric cancer. So the juvenile polyps, when you take a look at endoscopy, they tend to look like round balls loosely attached to the lining of the mucosa. So under the microscope, you see a proliferation of these epithelial cells, which is what's been shown right at the star. And sometimes these epithelial cells form these cysts. But the arrow is showing you the crux, what you use to diagnose a juvenile polyp, which is just an abundance of lamina propria. And for the most part, you see no smooth muscle proliferation in these polyps, but you can have a high degree of inflammation. So sometimes they get misdiagnosed as inflammatory polyps. So you have to have a high index of suspicion for juvenile polyps, and so sometimes so as to meet the diagnosis. So we're going to go on and speak a little bit about our neoplastic colonic polyps. Every time someone gets screening and they come back and they tell you, boy, they found a polyp, this is the polyp that they're usually talking about. These are adenomas, otherwise known as epithelial polyps of the colon with dysplasia. It is reported that about 30% of the US population has the neoplastic polyps. However, in our population, from the persons being screened, only 15% of the Jamaican population actually do have neoplastic polyps. So Dr. Kawich and Arthurs actually did a study on, I think it's a private patient group, and they found 480 polyps between 2015 and 2018, 480 patients between 2015 and 2018. And out of these, over these 4 years, only 70 persons had polyps. And that distribution you see there in the picture below, where most of these patients had right-sided polyps. So most of these right-sided polyps, they were all adenomas in the 70 patients, and only about 22 or so patients had more than one adenomatous polyp. I think Prof. Plummer and Dr. Cruikshank actually presented data looking at a larger population in Jamaica. It was actually around 3,000, and they found that around 15% of their population too had adenomas. So this is kind of standing true as compared to the US. And of course, in their study, most of the adenomas were seen in men. They're usually seen around about age 60. I think in the study by Dr. Kawich and Prof. Kawich and Dr. Arthurs, it was about 65. But for us in pathology, it's not just finding these adenomas. We take a look at these adenomas and we evaluate them to see exactly what type of adenomas they are. And for us, the adenomas are separated into three groups: the tubular adenomas, the tubulovillous adenomas, and the villous adenomas. So the tubular adenomas, these are the ones that tend to have these kind of short test tube-like crypts that are packed together. And then the villous adenomas are the ones that have these long, slender, a kind of filiform type of projections, looking like a fern. So if more than 75% of your polyp has that fern type appearance, that's a villous adenoma. If less than 25% of it has a fern-like appearance, it's a tubular adenoma, and the tubulovillous adenoma sits right in the middle. So this is a endoscopic picture showing the tubular adenoma, which gives me like mushroom cap type appearance that's disposed on this pedunculated stalk. And the picture on the right is what we would see in pathology, where this comes out, we fix it in formalin, so that's what's giving it that tan type appearance, and that's a portion of stalk that was resected. The black ink that you're seeing below, that's when we ink the specimen so that we evaluate to see whether or not there are any neoplastic cells that we can see with the naked eye extending to involve the margin. And if there are neoplastics or dysplastic cells out there, we inform the clinician, and the endoscopist could go back and remove the area. So the tubular adenomas with low-grade dysplasia, they tend to all look the same way. They look like polypoid portions of colonic mucosa with densely spaced tubules. And these densely spaced tubules are lined by these tall columnar cells. And these tall columnar cells have elongated hyperchromatic nuclei, and you tend to have a loss of goblet cells. So the picture on your lower right-hand corner is showing you normal colonic mucosa with portions of a tubular adenoma right and next to it. So you can easily see for yourself what we see under the microscope. The tubulovillous adenoma, here we have a nice tubulovillous adenoma that they actually took out at a colonoscopy. And you can see it doesn't have that mushroom cap. You start to see like these bosselated weird structures looking like what I showed you for the Peutz-Jeghers swab. So you can see how they can be easily mixed up at endoscopy. And it's again so pedunculated and supported on a stalk. And you go over here on your right, you will see that part of it kind of looks fern-like, part of it kind of looks tubular, which is pathognomonic of a tubulovillous adenoma lined by these epithelial cells. And if I had a higher power, you'll see that they kind of look just like the ones I showed you before. So this is the stalk of the polyp, and this is the stalk represented right there, and it's lined by normal colonic mucosa, and you can see the smooth muscle bundles from the muscularis mucosae going up into it. So this is a photomicrograph of a villous adenoma, and at endoscopy, you can see that most villous adenomas, they tend to be flat. They tend not to be pedunculated, and you can actually start to see the fern-like disposition even before you stick it underneath the microscope. The picture on your right is showing you one that's underneath the microscope, giving that typical fern-like disposition of these low-grade dysplastic cells. But in pathology, we evaluate and we do that just to identify that this thing is actually a villous or tubular adenoma, but we then hunt within it to make sure that you don't have any areas of high-grade change. And this high-grade dysplastic change is when the cells are starting to move from the normal colonic type phenotype to a more cancer-like phenotype. And the more cancer-like phenotype, you start to see irregular cribriform structures. So in your lower right-hand corner, you can see where the cells start to cluster, forming that sieve-like appearance, and that is your cribriforming. And if you look in the upper right-hand corner, you will see some small tufts of epithelial cells going off into the lumen. And you can see how ugly these cells are starting to look, and that is high-grade change. When you look at the nucleus of these cells, instead of them being small and hyperchromatic, they tend to be round and more vesicular. That means they're clear and you can start to see through them with prominent nuclei, and that's also another sign that there is high-grade change, as well as there tend to be increased mitotic activity in that region. We can't not talk about the newest kid on the block when it comes to adenomatous polyps, and this is the sessile serrated polyp or lesion. So this lesion was actually identified, I think, in the 1980s, but they didn't have a name for it. I think they just used to call them flat polyps and pink polyps and hyperplastic polyps. But Professor Emina Perlakovich, who I actually met, she's the one that actually came up with a sessile serrated adenoma, and they described a group of patients in 1996 that developed cancer just by having these lesions. And these lesions look nothing like the tubular adenomas that I showed you before. These sessile serrated polyps or lesions, or what used to be called sessile serrated adenomas, they tend to be in the right side of the bowel. They tend to be big. They tend to be more than a centimeter, most of them about 1.5 centimeters, and they're all flat. The funny thing about these things is that because they're on the right side, they tend to be underneath mucosal folds, and sometimes at endoscopy, they are missed. So it's actually suggested if you don't have high definition endoscopy that you should do some sort of dye or chroma endoscopy, which is what you're seeing on the right, where they squirted some dye on it just to see the outline of the polyp before you go and you try to remove it. This lesion is more common in women, and this is how they look underneath the microscope. So they tend to have that kind of serrated appearance with the small vesicles of mucin inside the epithelial cells, similar to what you see in the hyperplastic polyp. But as you go towards the base, it doesn't mature. In fact, they tend to have what's called a caudal growth pattern, where they grow along the muscularis mucosae and they start to branch out. Instead of the crypts getting narrow, they start to get wide, and they look quite irregular. And sometimes you can actually have conventional type dysplasia, similar to what you've seen before inside these lesions. But what we worry about is not polyps. We worry about the polyps eventually going to form cancer. And from the 1940s, there has been association with polyps and cancer. So when is it that we start to worry about these polyps? We start to worry when the polyps get a little bit bigger in size, right? So anytime you hear the endoscopy say that they found a polyp and the polyp is more than 2 centimeters, we start to worry that this is an advanced polyp. When they start to find a lot of polyps on the right-hand side, especially these flat sessile polyps, we tend to always kind of worry about these polyps. If someone who goes for routine colonoscopy at age 55 and they find 3 to 4 polyps, even some patients I see with 6 and 7 polyps, we tend to start to worry about these patients, and we tend to bring them back a little bit earlier, not give them the typical 10-year. We tend to come back in about 3 to 5 years to make sure we can evaluate this colon more, remove any more of these preneoplastic lesions. When we take a look under the microscope, or even before we look under the microscope, one of the things we worry about is these flat polyps, the ones that don't have a stalk. The ones that don't have a stalk, they're harder for the endoscopist to remove, because they tend to have little pieces over towards the edge that they can't see with the naked eye that extend, and they get left behind, and this can continue to propagate and form cancer. When we take a look under the microscope, we look for the varied patterns of growth, and the ones that are more villous, we tend to worry about them more. One, they're more flat, and two, they have more epithelium, and because you have more epithelium, you have more areas for mistakes to happen, and eventually for high-grade dysplasia to occur. And we know we worry a lot about high-grade dysplasia. If you have a sessile serrated polyp, with or without dysplasia, as long as you have that lesion, we tend to ask the patient to come back within 3 to 5 years to make sure that their colon is necessarily evaluated, because a lot of these patients tend to have what's called interval cancers if you leave them a little bit too long. So we're going to go back to our index case, and eventually this patient did have her surgery done, and this is what we saw when we received the specimen in pathology. So remember I tell you that we get it and we cut it open. And when we cut it open, there were numerous polyps, so many polyps we could not count. It completely coated the mucosa. So turn towards the left-hand side. This is just showing you normal mucosa. And then up by the arrow, this is when you start to see so many polyps. We have pedunculated polyps, we have sessile polyps, we have polyps of every shape and size. So most of these polyps were less than a centimeter, but we still had a large majority or a large minority that were over a centimeter. The largest one was actually in the cecum, and it was 4.5 centimeters in size. And the largest polyp Actually, I took some pictures I show you what happened in the largest polyp. So in the largest polyp, up on the top, we have these densely spaced tubules looking typical like a tubular adenoma. And as we start to go a little bit caudally, we see that we start to have weird kind of fusing and cribriformness. And then as it pushed inside the submucosa, you can see it now initiating a desmoplastic response on the right-hand side, and then the neoplastic glands extended to involve the muscle itself. So the largest polyp, which is, I tell you, we always worry about the big ones, the largest polyp had both villous and tubular type growth. It had high-grade dysplasia, and that cancer arose within this one. The only good thing is that the tumor was actually didn't extend beyond the smooth muscle bundles of the muscularis propria. So it was actually a T2 tumor. So this is a patient that has an APC gene mutation and has familial adenomatous polyposis. And we stopped counting. We just had over 100 conventional type adenomas with both low-grade and high-grade dysplasia. The good thing, though, is that the resection margins were clear, and we just have to follow this patient up, as well as do genetic studies and advise the rest of the family. So in summary, no colonic polyps. The colonic polyps are not the same. Even the colonic polyps of the epithelium, they're all different. We have non-neoplastic polyps and we have neoplastic polyps. And even the non-neoplastic polyps, such as the hamartomatous polyps, they too can have hamartomatous polyposis syndromes that predispose you to get cancer. In the neoplastic polyps or the pre-malignant polyps, the ones that we tend to know, we want to know about are the conventional adenomas with their varying degrees of dysplasia. And of course, we have to look out for them sessile serrated polyps or lesions. But we don't have to worry, right? They do have worrisome features, but we do have management algorithms in place, and we do have the expertise so as to manage these advanced polyps. So this is actually the only good news I have for you guys today. Here are my references, and thank you, and I will take any questions.
Okay, thank you very much, Dr. Thompson. Are you with us live? Yes. Thank you.
Yes, I am.
Yes, please feel free to address Dr. Thompson in the Q&A. There are opportunities to ask questions about colon polyps to Dr. Thompson at this time. Perhaps I'll start with a question for you, Dr. Thompson, and perhaps maybe not want to know the answer, but can you give us an idea as to the correlation between the size of the polyps found or reported at our colonoscopies compared to what the pathologist actually sees when the specimen returns? Is there a good correlation? And the description of the polyps as well, because we do sometimes indicate to you that we think it might be, an adenoma or hyperplastic, for example.
Well, from the question, you realize that we've had this conversation many times. So when we talk about the size of polyps, it's not the size of the polyps that we get at pathology. It's usually the size of the polyps that the endoscopist or clinician send to us. And they have their ways of measuring the polyp at endoscopy using the probe, or I don't know what else you guys use. But when we put the tissue in formalin, the tissue actually shrinks. So what they take out is a 2 centimeter polyp, for the most part, usually becomes a 1.5 or even a 1.4 centimeter polyp. But even looking at it grossly, we can start to see irregularities where the cribriform areas start to become a little bit more tough. And we can actually evaluate and see little areas of hemorrhage that's kind of really suspicious that this thing is more of an advanced polyp. So the correlation between what you see at endoscopy and what we see at pathology is actually quite poor. So I guess that's why we have to make a lot of our calls underneath the microscope.
Okay, thank you very much. And with that in mind, do you see a role for more advanced endoscopes being utilized to make a histological diagnosis at the time of colonoscopy, for example, confocal laser endoscopy or narrowband imaging, all of these techniques which supposedly give us more detailed imaging? Do you think these are useful or just novel techniques?
Well, I think they can be more useful, but it's all user dependent, right? So it doesn't make any sense someone tries to do confocal microscopy or confocal endoscopy, and they're not really, they weren't really trained to do it, because then you'll start to make overcalls just based on the literature. So there is a role for it, just as how there was a role for chromoendoscopy at one point in time. But with this high definition and with the varied endoscopic procedures that you guys are doing now, and I think Dr. Fairclough's going to come back soon and start to do submucosal dissections and stuff at endoscopy. I guess we'll wait and see what he does and see, and that I will definitely have a better answer for that question at a later date. But we have to see these new techniques here before we actually comment on them.
Okay, thank you very much. Are there any questions in the chat? No, I'm not seeing any questions at this time. We will allow opportunities to answer any questions as we go along, so please feel free to post those. The symposium will be available for viewing afterwards for those who have come in late also, and your CMEs will be sent to you electronically as per usual. So thank you again, Dr. Thompson, for outlining the colon polyp history and progress for us today. And we look forward to your continued interaction with the Cancer Society going forward. So I'm going to take the opportunity then to go on to our next speaker. And this speaker comes to us from the Bahamas. So he is not a stranger to the island of Jamaica. He actually has been here numerous times, and I'm referring, of course, to Dr. Floyd Carter, who is practicing in the Bahamas at the Gastroenterology Clinic and is a consultant gastroenterologist and is the medical director at that same clinic. He is a graduate of the University of the West Indies class of 1999 and has his postgraduate DM from the internal medicine program in Jamaica and did his fellowship at McMaster University in Canada. His special interests outside of the world of GI include youth development and music. And he's going to speak to us today about colon cancer screening. Is colonoscopy still the best tool for screening? And he comes to us from the Bahamas, but is well versed to address all aspects of screening. Welcome, Dr. Carter.
Good morning. Allow me to first say thanks to the organizers of this symposium for inviting me to speak. I have been assigned the topic colorectal cancer screening. Is colonoscopy still best? I've taken some liberty with the topic and adapted it slightly to scope, to scan, or to stool. I have no disclosures relevant to this presentation. The aims of this presentation will be to give a bird's eye view as to why colorectal cancer is important. Then we will dive into the subject matter. What are the aims of colorectal cancer screening? What would be the qualities of the best screening test? We will then evaluate our available screening options using this lens, and then hopefully arrive at an answer to our question, which screening option is the best. Let's get at it. In 2020, the World Cancer Observatory published data that confirms that colorectal cancer remains the third most common cancer. The top three: brain, breast, lung, and then of course, colorectal cancer. Of course, the incidence varies from place to place, with highest in Hungary and South Korea, with the lowest in African countries and Asian countries. In the United States, for example, 1 in 23 men and 1 in 25 women are at risk, will develop colorectal cancer over their lifetime. So it's common. Here in the Bahamas, where I practice, the top three causes are prostate, breast, and number 3, yes, colorectal cancer. In Jamaica, the situation is quite similar as here in the Bahamas: prostate, breast, and colorectal cancer. So this cancer is common. This cancer is also lethal. The statistics show that colorectal cancer is the second most common cause of cancer-related death in the United States and many parts of the world. So it's both common and it is lethal. What are the aims of screening of colorectal cancer? There are two. Number one, the early identification of the colorectal cancer that will allow for a possible cure of this condition. This is important. This is an important screening goal of most screening tests we have for cancer. But in addition, an additional aim is the identification and the removal of precancerous lesions, such as adenomas and sessile serrated lesions. It is important when we are analyzing which screening test is the best to also consider, does the screening test allow us to accomplish these two aims, early identification of the cancer and possible identification and then removal of precancerous lesions. Here are 6 qualities I have listed that are considered ideal qualities you expect in a screening test. You want the test to be non-invasive. You want the test to be highly sensitive and highly specific. This is important. A highly sensitive test will allow you to detect the disease if it is present. So you will have a very low false negative. A highly specific test will allow you to rule out conditions, particularly if patients does not have the disease, they will test negative. So you want a very low false positive. But I like this quality because it tells you that you can trust the test. The test should be safe, it should be readily available, should be convenient, and preferably inexpensive. These are the qualities that we'll be looking at with our screening options today. So what are the options available for colorectal cancer screening? I stole this slide from UCLA Health, and it divides screening tests into stool-based strategies and direct visualizations techniques. The stool-based strategies mainly look at microscopic blood, and this is the guaiac-based fecal occult blood test, FIT, which is fecal immunochemical test. And the third test is a stool DNA test that rounds out the stool-based strategies, which we have as Cologuard, marketed as Cologuard. The direct visualization techniques include CT colonography, flexible sigmoidoscopy, and colonoscopy. There is a blood test for screening for colorectal cancer, approved by the FDA. This test hasn't broken through into widespread use. It looks at a methylated septin-9, and there's also the colon capsule. These two tests deserve mention, but they are not commonly used screening tools. So let's look at the fecal occult blood test. This test detects blood in the stool based on a chemical reaction. And this chemical reaction hinges on the peroxidase activity of heme. The whole concept here is that if there is the presence of colorectal cancer or some polyps, these lesions can bleed, and this blood can be detected by this test, prompting an examination of the colon. The advantages of the fecal occult blood test is that it's simple to complete, it is cheap, and it can be performed at home. The drawbacks of this test is that the false positive rates can be quite high. So therefore it has a very low specificity. And that's because other dietary peroxidases can cross-react with this test, particularly broccoli, cauliflower, turnips, or even squash. And in addition, it does not differentiate between the heme in human blood and the heme in myoglobin in the red meat. So people who eat red meat will also have a false positive test. Antioxidants like vitamin C can inhibit this chemical reaction. Another significant disadvantage of fecal occult blood test is that it is not specific for colonic blood. So blood from the upper GI tract, stomach, and small bowels can also give you a positive test. And an additional important point to know is that several stool samples are required to perform this test properly. And this is typically done over several days. So this can be inconvenient for some patients. So in general, you need specific dietary restrictions and you need several tests to be performed. If this is your screening option of choice, it should be done every year, starting at the age of 45. If it is positive, a colonoscopy is recommended. We have evidence to suggest that this form of screening will reduce colorectal cancer mortality. In this article published in 1993 from the New England Journal of Medicine, looked at over 46,000 patients tested every 2 years or annually. They found that a 16% reduction in mortality from colorectal cancer, and this rose to 33% with annual fecal occult blood testing sustained over 13 years of the study. In addition to colorectal cancer mortality, there's also a reduction in the incidence of colorectal cancer, with biennial testing giving you a 17% reduction, rising to 20% with annual testing. So this is the scorecard for fecal occult blood tests. It is safe, not truly convenient because of the several samples needed over several days and the dietary restrictions, drug restrictions that are needed. It is non-invasive, but it's not highly sensitive nor highly specific. This, I think, is important to be able to trust the test. It is available and inexpensive. So obviously a better test is needed that allows you to look for microscopic blood, and FIT was developed. FIT is fecal immunochemical test. This test improves on some of the weaknesses we've already identified for the fecal occult blood test. This test is specific for human blood because it detects the antibody to human globin. So only human blood will react. This test is specific for colonic blood because even though you can bleed from the upper GI tract, the globin in the hemoglobin will be digested as it passes through the gastrointestinal system. So only the globin that is released in the colon is detected or that is preserved. Let's put it that way. No dietary restrictions are required, and a single stool test can be performed. As expected, the FIT performs better than the fecal occult blood testing in detecting advanced adenomas and colorectal cancers. Even though it's better than the fecal occult blood test, the overall sensitivity for identifying colon polyps is low. And that's intuitive because it requires the polyps to bleed, and not all polyps bleed. Actually, most of them do not bleed. So you can miss a lot of polyps using this strategy. Despite that, we can see it's very effective for the detection of colorectal cancer at a rate of 95% with relatively reasonable sensitivity and specificity. In a FIT screening program in Italy, they screened 7,000 patients over a period of 11 years, and they found that this screening test allowed them to have a 22% reduction in colorectal cancer incidence. So it is an effective tool. So this is the scorecard. And as you can see, it performs very well when it looks through the lens of the qualities of a screening test that we will like. It's safe, convenient, non-invasive. It loses marks for its sensitivity because it does not allow us to achieve that goal of true identification of precancerous polyps unless they're bleeding, and otherwise it performs quite well. Rounding out the stool-based strategies is the stool DNA testing. The concept here is that in colorectal cancer, exfoliated cells will exhibit mutated DNA. And the stool DNA basically looks for these markers, and a variety of markers are looked for listed here. And they combine this stool DNA testing with a FIT testing for blood. So this test has been approved by the FDA since 2014 for the screening of colorectal cancer. Analysis of this test showed, compared to the Cologuard to FIT in patients who were undergoing colonoscopy, found that there was a higher sensitivity for detecting colorectal cancer, very good, 92% versus 74%. There was a higher sensitivity for detecting advanced adenomas, 42 versus 24%. And there's a higher sensitivity for detecting of sessile serrated lesions, 42% versus 5%. FIT testing does not identify these lesions properly. So those are good. But when you look deeper at the data, 42% of sensitivity for advanced adenomas still means you're missing over half of the polyps. So this test still isn't good for identification of polyps. And it is not as specific for colorectal cancer or advanced lesions compared to FIT. So when you model these options, annual FIT versus colonoscopy every 10 years versus stool DNA testing every 3 years, actually FIT and colonoscopy was found to be more effective and actually less costly than the stool DNA testing. So here's the scorecard for stool DNA testing. Not bad, safe, convenient, non-invasive, but where I think is more important, and if you can trust the test in sensitivity and specificity, it falls down, it is available, and it costs over $600 a pop, so it can't be considered to be inexpensive. Let's look at the direct visualization techniques. Virtual colonoscopy, or CT colonography, is a non-invasive, low-dose CT scan. It allows you to reconstitute 2- and 3-dimensional images of the colon. The advantages of this test that compared to regular colonoscopy is that it requires no sedation and it has a lower risk than optical colonoscopy. And to some, an advantage would be identification of extracolonic evaluation. I personally think this is more a disadvantage than an advantage. And other disadvantages are you require the same preparation. There is some discomfort with a rectal tube being placed to call for insufflation of the colon. And all of this is done without sedation, so it can be an unpleasant test. Even though the perforation rate with a virtual colonoscopy is lower than a regular colonoscopy, the perforation risk still exists, about 0.05%. And patients are exposed to contrast or risk of contrast allergy. And of course, there is radiation exposure. And also consider that this is a test that will be repeated as your screening options. There may be a potential risk for radiation-induced cancers. And of course, if the test is positive, a colonoscopy will be required. Comparing virtual colonoscopy to actual colonoscopy, you find that there is a similar sensitivity for the identification of large polyps and identification of colon cancer. There is a reduction in sensitivity for polyps that are smaller than 8 millimeters. But when you compare the specificity of these procedures, you find that they perform quite well. Colorectal CT colonography actually may be more specific than colonoscopy in some studies. So if you choose the CT colonography as your screening choice of your option here, it is required to be performed every 5 years and starting again at age 45. Our scorecard shows that it is safe, not truly convenient because it still requires the same prep and unpleasantness of the air insufflation. It is non-invasive. It loses sensitivity marks because of it's not as good for identification of polyps under 8 millimeters. It is highly specific, available, and can be considered to be inexpensive. Now, the optical endoscopy options are flexible sigmoid endoscopy. In this process, you examine the left side of the colon. And the concept here is that the majority of colorectal cancers do arise within the distal colon. So this allows you to examine that area. And also, if you can identify any precancerous lesions, they can be removed at the same time. However, this is also a two-step process because if any polyps or lesions are detected on the left side, a full colonoscopy is required. Fortunately, there are significant randomized control trials that have established the efficacy of flexible sigmoidoscopy in both the reduction in colorectal cancer incidence and reduction of colorectal cancer mortality. And some places in the UK actually use this test as their preferred screening option, mainly because the patients do not require sedation and it can be easily performed and does not require the highly skilled technique that is required for an actual colonoscopy. There have to be some evidence, however, that it may not be as effective in women. That's an important topic for discussion that we can discuss at the end of this talk. Colonoscopy is the gold standard for screening. The reason why we call it the gold standard because it has the highest sensitivity and specificity. In addition, it allows us to accomplish the two aims of screening, which is early identification, allowing for a cure, and the identification and the removal of both adenomas and sessile serrated lesions. It is no wonder then it is a definitive test that is done when all of the other screening tests are positive. This is the only single step process available for colorectal cancer screening. It is still considered relatively safe. The perforation rates typically is quoted as less than 1 in 1,000 cases. It does require full bowel preparation and sedation, so it's not convenient nor comfortable for the patient, and is not easily affordable to the general population. These factors make colonoscopy an excellent test for screening, but not great for mass screening of a population. There is evidence to suggest that colonoscopy as a screening option allows the reduction of colorectal cancer incidence and colorectal cancer mortality. There was some emerging evidence, however, that gave us some concern that the reduction wasn't uniform across the colon. Look at this article published in Gastroenterology in 2020. This did see that there was a reduction in colorectal cancer mortality with colonoscopy for screening. But when they divided into the reduction in mortality for distal cancers, which is left-sided cancers, versus proximal cancers, right-sided cancers, they found a 42% reduction in distal colorectal cancer mortality, but no reduction in mortality from proximal colorectal cancer. And this was alarming for endoscopists because this is a whole reason why we prefer to do an entire colonoscopy, because we can see the proximal colon. And here, this article suggested that it wasn't reducing mortality. Fortunately, other studies have shown different, that this one here, a large study from the Nurses' Health Study and Health Professionals Follow-Up Study showed that there was a reduction in mortality from colorectal cancer after screening colonoscopy with a 68% reduction in risk, very significant. And the reduction in mortality was also found for those with proximal colon cancer, a 53% reduction in risk. So this was a sigh of relief for us. But it's still a concern that we may not be doing as well in the right colon as we do with the left colon. And this, again, for different reasons. If colonoscopy is the choice of screening, then it's recommended every 10 years, starting at the age of 45. But how does it perform through the lens of the quality testing, qualities of the test that we want? As you can see, it doesn't perform as well. It's safe, it's not safe. Well, we consider it safe, but it is offers the greatest risk of all of the options that we've discussed so far. Can't be considered convenient, can't be considered non-invasive, performs excellently with sensitivity and specificity, so you can trust this test. Not readily available, and is not inexpensive. So it doesn't perform as well with in our context of quality screening tool. So which test is the best test? At face value, it seems that FIT performs the best, ticking most of the boxes, and colonoscopy performs the worst. But when you really look deeper, when you look at the sensitivity and specificity, can you trust this test to do what it's supposed to do? You can see here that colonoscopy performs the best. So it's the most effective test. And FIT probably will be the second most effective test. So which test is the best test? Forgive me for saying this, but I have to say any screening test that is acceptable to the patient and that the patient is willing to compete and to continue is the best screening test. Because any screening is better than no screening at all. Second thing we have to consider is that colonoscopy is a single step test. It allows the identification and the removal of lesions. It is the end test. If all the other screening options are positive. So when you interpret the efficacy of the other screening tests, enfolded in that data is performing a colonoscopy if the test is positive. So opportunistic screening is where we test patients when they present to the doctor. And this is what is practiced in the Caribbean and in most places in the United States. It's no surprise then that when you catch the patient at that time, you offer them the single best test, and that is a colonoscopy. And a colonoscopy is the preferred test for opportunistic screening. If the patient does not want or wish to have a colonoscopy, then they should be offered one of these secondary tests that we have mentioned. And in my opinion, the FIT test, the FIT should be what should be offered, or the CT colonography. For programmatic screening, this is where there's an organized, systematic way of identifying an at-risk population and inviting them to participate in a colorectal cancer screening program. In this case, you want convenience and efficacy together in one. And there's no doubt that hands down that FIT performs the best. It is the best test for organized population screening programs. In places of the states, the stool DNA testing is being used, but there are, in my opinion, there are significant drawbacks to this test other than its expense. It's not as specific, not as sensitive. So I think the FIT outperforms the stool DNA test, in my opinion. So in conclusion, instead of summarizing what we have already said, I want to take a few seconds of my remaining time to challenge my colleagues and myself. I think it's high time that we move to a more organized colorectal cancer screening. We need programmatic screening techniques within the Caribbean. Opportunistic screening has taken us thus far, but we really need to do a better job because colorectal cancer is preventable. Every death, or let's put it this way, 85% of deaths related to colorectal cancer are preventable. And we have an ideal test, which is FIT testing, that's well suited for these programs. So in conclusion, is colonoscopy still best? My answer is that it depends. Thank you.
Okay, thank you very much, Dr. Carter, for thought-provoking, stimulating talk on colorectal cancer screening. We do invite questions to be posted in the Q&A, and I know Dr. Carter will join us live to answer those questions. I'm going to start with the first question, which was posed at the end of Dr. Murphy's talk. And perhaps if you want to just answer for us, Dr. Carter, at what age do we stop screening?
Hi, good morning again. So the recommendations are that we plan to do screening between the ages of 45 and 75. I think most societies will recommend that age period, 45 to 75. Screening above 75 will have to be taken on an individual basis. So you have to know your patient. So the whole concept here is that screening, if you perform a colonoscopy today and remove polyps today, the benefits to that patient are not really isn't accrued until 7 to 10 years later. So basically, you need to look at the patient's expected lifespan. And typically we say if you expect lifespan is less than 10 to 15 years, you should not be performing a screening colonoscopy in that patient. And we're talking about screening colonoscopy. We're not talking about performing a colonoscopy because of an actual reason, such as blood in the stool, excessive weight loss, and so forth. But just performing a screening in an asymptomatic person who's elderly, that have a lower life expectancy is not recommended. So basically the answer to that question is if they are over 75, I basically look at their age and also how they look, their life expectancy, and then make a decision based on that.
All right, thank you very much. Can you please also discuss fit testing compared with colonoscopy? I know you did go through it, but this question was posted earlier as well.
Yeah, I think the scorecard shows you fit test does very well for both reduction in colorectal cancer mortality and reduction in colorectal cancer incidence. As far as analysis of the test itself, it is specific for colorectal cancer, does as well to me as colorectal as colonoscopy, but as far as the sensitivity, it falls down in that area because it's not good for the identification of polyps or advanced polyps. So that's where it becomes an issue. Depends on what your goal is for screening. If your goal is early identification of the cancer, then FIT is useful. But if you also want to attain the secondary goal, which is identification and removal of polyps, that's where it becomes less effective. But as far as a programmatic screening, I think it is, as far as convenience, it is a test that we should be using and try to get access to. There's no doubt in my mind, I'm a little biased. I think colonoscopy is the preferred test, but on a population base, if I'm starting a population-based screening, I would personally choose a FIT test over colonoscopy.
Is it readily available in the Bahamas?
It is, but not readily, no. And I think that is demand. I'm sure if we start asking for it, we'll have it. So part of that problem is us. We are comfortable with the fecal occult blood test, but I'm not sure how many of us are performing it properly. Are we doing the strict dietary restrictions, strict medication restrictions as necessary? Are we collecting the 3 required consecutive samples to do it properly? Otherwise, we're using a test that has very low sensitivity. But any screening is better than no screening at all. So if that was available, you have to use the tool, but try to use it as properly as you can.
Okay, thank you. Also, someone is asking, if someone was evidence of bleeding and change in bowel habits, what is the rationale for doing a virtual colonoscopy over a standard colonoscopy?
Typically, remember we were talking about screening, and that's basically testing an asymptomatic patient. If the patient has symptoms, I think all bets are off. You should go to the single best test. Patient should have a colonoscopy. If the patient refuses, does not want to have a colonoscopy, then you offer them one of the other options. And in that case, I think a luminal testing, as Dr. Murphy was mentioning, CT colonography should be offered. Or if they would prefer having a flexible sigmoidoscopy, unsedated, maybe an option in that case. But once they have symptoms, I typically will offer the patient a colonoscopy and discuss the benefits and the risks and have the patient decide if they want to proceed with that or not.
Okay. Another question. Patients post-surgery for colorectal cancer should do, or they're asking if you should do a yearly FIT testing. So this is surveillance.
No, they should have colonoscopies. Colonoscopy at year 1, 3, year 5. Once they've had colon cancer, they are high risk. And those options that we have mentioned are average risk screening. Once you've had a history of colorectal cancer, you want to be removing precancerous lesions, your risk of another cancer goes up, as we all know. So you want to offer them the single best test. That would be a colonoscopy in that case. I would not recommend stool-based strategy for surveillance.
Okay. And how does family history impact your screening protocol?
Well, family history is important. So it depends on who in the family has the history. First degree relatives of colorectal cancer, that patient is high risk. And number one, the screening should start at age 40 and then be performed every 5 years. Or you look at the youngest affected relative, and 10 years before that person was diagnosed will be the time that you start your screening. If they are second degree relatives, then it's a little trickier. If it's only one second degree relative, it doesn't change my screening approach. I will screen them as an average risk person starting at age 45 and every 10 years. But if they're more than one second degree relative, then I personally place those patients in the higher risk group and perform the colonoscopy at age 40, and will recommend the colonoscopy as the preferred screening option in that case.
Thank you. Okay, and a follow-up from the question about the virtual colonoscopy. So Dr. Lewis Bell is saying she agrees that the standard colonoscopy should be the best, yet a relative with these signs and symptoms was offered a CT colonoscopy and ended up still having to do the regular colonoscopy. So I'm not sure if that's just based on what was found at the CT, then requiring the colonoscopy after.
Yeah, so I didn't hear a question there.
All right.
But that's correct. You have to understand that all of the other screening options are two-step process for screening. The patient has to be advised that this is not a way to avoid colonoscopy, because if the test is positive, for the screening to be effective, they have to be offered a colonoscopy. And so they're not considered screened just based on a positive stool cut blood test. They only really screen if it's positive and they went on to get a colonoscopy. That's where they get the benefit that we see in the literature. So the only one-step process is the colonoscopy. CT colonoscopy is useful. I use it in my own practice for patients who really can't get to the end of the colon for. Otherwise, it will have to be the patient's choice that they will prefer that than an actual colonoscopy. But I do tell them that if you go this route, if we do see anything, we'll still offer you a colonoscopy after.
Yeah, I mean, I just addressed Dr. Lewis Bell as well to say that I think perhaps in this patient, what is often done is that you try and look at the risk and versus benefit for the procedures. And if it is, for example, in this particular patient with bleeding, that it was thought that the likelihood of requiring a biopsy or a diagnosis which required a colonoscopy was fairly low, and the risk of doing the colonoscopy was fairly high. So for example, an elderly patient who presented with, the first time bleed, and you really don't wish to subject them, or there was a hesitation to subject them to an optical colonoscopy. Perhaps if, for example, a diagnosis would have been offered at the virtual CT colonography, then that patient may not have required the colonoscopy, and then in that way would have had a reduced risk of exposure in that sense. So there is some rationale to doing it. You do need to look at the patient, as Dr. Carter says, and decide what the risks are of each procedure and the likelihood of having to follow if no diagnosis is made on the CT, or if a biopsy is necessary. So that has to be borne in mind as well. Other questions here, quite a few questions coming up. The cost of fit testing. I know you did mention, or did you mention a cost? Do you have a cost in the Bahamas? I know in Jamaica, someone mentioned in the chat from Biomedical, but I'm not sure what the cost is. Perhaps that person can place it in the chat.
The cost quoted is typically around $20, $25 US for the fit test. Of course, it all depends on what your suppliers are, and understand that there are different types of fit tests. There's a qualitative test that gives you just a positive and a negative, and there are quantitative tests that actually gives you a amount of blood or hemoglobin per gram of stool that allows you to play with the cutoff range a little to increase or decrease the sensitivity. But most societies will recommend this, the qualitative test, positive and negative. And so that should be a cheaper test than the quantitative analysis, around $20, $25, a little more expensive than the fecal blood test. But if you look at 3 samples versus 1 sample, you might actually end up to be about the same cost.
Thank you. Interesting question here from Dr. Francis Emmanuel. Says, good day, Dr. Carter. For those patients with acromegaly, in whom optical colonoscopy may sometimes prove challenging based on luminal size and length, would you consider alternating CT and optical colonoscopy, especially as screening frequency is higher than those for average risk, those at average risk?
Of course, if somebody is known to be a difficult colonoscopy, there are some patients who are just routinely difficult, then CT colonoscopy will have a role in that case. Remember, those patients with acromegaly do have a higher risk of colon polyps. So I really won't consider them average risk screening, will be slightly higher risk. So you would prefer to offer them a colonoscopy as their preferred screening option. But yes, if it is difficult to get around, you probably want to save that difficult procedure for when you know that maybe something significant in the bowel to remove. So I won't have a problem with that strategy that you outlined there.
Bear in mind that if it is difficult to reach, sometimes you wonder if, once you do the CT, if it shows something, how are you going to go and do a biopsy afterwards? You do need to prepare for that challenge as well.
Right, it does prepare yourself for a longer procedure, right? So, and we can do that longer times. That's the problem. We have our patients booked in small sections of time. And so if you prepare for a tough case, you can allot an hour or so forth on your list for a particularly prolonged procedure.
Okay, question here, is colonoscopy relatively safe to be performed on all individuals?
Depends who's performing it. That's the best way I can answer that. A colonoscopy is safe. As a gastroenterologist, practicing doing colonoscopies the last 15 years, I would say it's a safe test. But comparatively to all of the screening options that we've mentioned today, we have to say that it offers the highest risk of all the options we've mentioned, but the most effective tool. So I would say between the age of 45 and 75, I personally will offer colonoscopy as the preferred tool for screening. So I think it's safe for all patients between that age, unless of course there are other comorbidities that you have to pay attention with. So not all patients, there's no absolutes here. There's some patients who a CT colonoscopy will just be best, but most patients who've had a CT colonoscopy don't want it again. If they've had a colonoscopy after, they were like, why? Because the difference between comfort level and so forth is a lot different. So I think it's safe, I would say that, but you want to make sure a skilled person is performing the procedure. Unfortunately, in Jamaica, you have a lot of those, so you have good options for accredited, safe practitioners to perform your procedures.
Okay, so another question here. What would be the screening protocol for post-neoadjuvant chemoradiation with complete radiological response? How frequent and what? So again, about surveillance. And it just follows up, especially when the surgeon wants to keep the patient on wait and watch protocol.
Not understanding. This is somebody who had a colorectal cancer, and they
seems to have had a rectal cancer, maybe had chemoradiation, radiological response. Not sure if the person actually had
surgery.
resection. Yes, that's right.
Exactly. So that part I don't understand. Typically, for me, if a patient has a rectal cancers to me are different. Is a different beast altogether than a colon cancer. Number one, they are very radiosensitive to radiation. So if the patient has had significant response to radiation treatment, and you can confirm that endoscopically, I would really go back in and biopsy everything. Make sure that you're comfortable with that. But I don't know. Typically for my patients, I do recommend they have the lesion removed if it's possible. But if you want to do a watch and wait, that would be fine if the patient is willing to accept that risk. I'm not sure as a clinician, that would be what I would advise the patient. If you have a rectal cancer, I would say if possible, and you can spare the patient having a colostomy, then I think my suggestion would be proceed with surgery to remove the affected area. But I'm not a surgeon. That's my caveat there.
Sure, no problem. And I think Dr. Roberts will be on later. He can also address that question. In the chat I'm seeing here again from one of our attendees, the cost at biomedical was about 20,000 some time ago, but it may have changed with the exchange rate. So that's for the fit testing.
How much is that in US? Remind me, Dr. Mill, sorry.
Okay. I have to calculate that, Floyd.
Sorry.
20,000 divided by too much.
Yeah, that's right. I just wanted to know so I could compare. See
let's see. They're about 120 US or so.
Yeah, so that's a bit on the high side.
Yeah.
And for my information, what about the blood test? How much is that per test? Are you aware?
No, we don't. Which one are you referring to? The Cologuard?
No, the fecal occult blood test.
The fecal occult blood test. No, that's nominal. That's I don't think it's more than a few $100 actually. It's part of the regular screening protocol.
Okay.
And I see another. Is AI available in the Caribbean? How does this add value to colonoscopy? So artificial intelligence and I suppose robotically assisted colonoscopy. Is this something that is here yet? And do you think it's something which we need to get into?
It's where we're heading. There's no doubt about it. Do I think we'll get to the stage where a robot will be performing the procedure? I don't think so. I won't relinquish, at least not during my practice career. I hope not. But we're using some type of intelligence now. In my unit, we use specific tests, or what we call optical scanning, optical enhancement of lesions, that allows us to perform, that mimics what we call just like inducing chemicals into the bowel and so forth, chromoendoscopy as they call it. But we're able to do that now with the highly sensitive and test procedures and colonoscopes that we have today. So we're using it now, but to the extent that a robot itself will be performing the procedure, there are people out there who are studying this with fairly good effects, but I don't think in the Caribbean, fortunately, we'll be a little delayed on that.
Yes, definitely. And as we mentioned, there is a lot of software that actually helps with pattern recognition, which you still do the procedure, but as you do, it can either mark points that are abnormal or flag places that need to be biopsied, for example. Not sure if there are any other questions. I do note that someone has their hand up in the chat, but I don't know if we're able to open a microphone for that individual. We can take a couple more questions here. I see someone asking about capsule endoscopy. Does it have a role outside of small bowel evaluation? So the role of capsule endoscopy in screening, perhaps?
It is approved, the colon capsule. So you have to make sure you use a colon capsule, not a small bowel capsule, because they are different. But yes, they are available for colon cancer screening. Very, very good. But remember, you still have to do the bowel prep. Patients need a very clean colon. And if you see something, of course, you still will have to go and perform a actual optical colonoscopy. Yes, so, but it's expensive. I can't see it being offered at a lower price point than a regular colonoscopy. Capsule endoscopy is the highest costing procedure that we offer in my practice.
Seeing the chats, and I'm seeing attendees with hands up: Daniel Walters, Jelani Stevenson, and Dr. Webb, Nicola Beckon. But I'm not sure if you want to ask a question live or if you want to type it in the chat. Or we can open the microphone if necessary. So perhaps our technical team, perhaps you can open the microphone for one of these individuals if they'd like to ask a question, if they're not able to place it in the Q&A or chat. David, are you able to do that for us?
Yes, I did, and I'm asking the person to unmute and speak.
Okay, thank you. Okay, I'm not sure if they're having their hands up accidentally or they actually intend to. But you can type it in the Q&A, and if necessary, we can address those questions at another time. So thank you very much, Dr. Carter, for being a part of our symposium, and we look forward to your continued contribution, and wish you all the best. All right, so at this time, we're going to move on to our next speaker. And all of our speakers have been wonderful today. They're all excellent and leaders in their field. But definitely our next speaker, I would say, is an eminently qualified contributor to our symposium today. And it gives me great pleasure to introduce Professor Subrata Ghosh to the symposium this year. So thank you very much, Professor Ghosh, for accepting our invitation. He is the chair of medicine and the head of medicine at the College of Medicine and Health at University of Cork in Ireland. And he's been there since last year, March. He is the principal investigator and deputy director at APC Microbiome Ireland, and recently been awarded a significant professorship at that institution. He has done countless hours of intense, hard, and well-received work in the fields of inflammatory bowel disease and immunotherapy related to inflammatory bowel disease, looking at the interaction with the immune system and the gut microbiome. He is extensively published in the New England Journal of Medicine, Lancet, Nature Medicine, Gastroenterology, Gut, American Journal of Pathology, American Journal of Clinical Medicine, and delivered hundreds of international invited lectures and numerous invitations and acceptance to be a key. He has practiced at in numerous different healthcare facilities across the world, really. And between 2009 and 2016, he was professor and chair of medicine at the University of Calgary in Canada. And prior to that, he was in the UK, where he was professor and chair of GI at Imperial College London at Hammersmith Hospital. He's a fellow of the Academy of Medical Sciences in the UK and the Canadian Academy of Health Sciences, and is a second member from Ireland to sit on the prestigious International Organization for Study of Inflammatory Bowel Disease. And with all this wealth of experience and expertise behind him, he has graciously accepted to speak to us this morning at our colon cancer symposium. And the topic which we've asked him to speak to us about is the gut microbiome and cancers. So please, Professor Ghosh, welcome, and we look forward to your lecture. Thank you.
So thank you very much, Dr. Mills. I hope you can hear me loud and clear. And so this was a very kind invitation and a very kind introduction, and thanks a lot for that. As you mentioned, I have spent half my life in inflammatory disorders of the intestine and designing drug therapies for it. I moved to Ireland and to Cork because it has one of the world's best microbiome centers in the world, and also one of the best food science centers in the world together. And I moved because I thought, especially in my field of inflammatory bowel disease, the microbiome and the food are very key to really try to solve these debilitating diseases. But quite frankly, you can't get into microbiome and food without becoming interested in colon cancer as well. So I'm going to talk today about the gut microbiome and the link with colon cancer. But some of the concepts that I'm going to talk about are also true for many other cancers. And my increasing interest in the field of cancer is how microbiome and food modulates the efficacy of therapies, especially the immune checkpoint inhibitors, which are now being increasingly used, and also try to reduce some of the adverse events of immune checkpoint inhibitors by intervening and modulating the gut microbiome. So I would thank Jamaica Cancer Society also for this invitation to the colon cancer medical symposium today. I enjoyed the 3 previous lectures greatly, and hopefully I will be able to convey certain messages to you today. So no conflicts. So you all know that as the American Cancer Society articulated, there are colorectal cancer risk factors that can be changed: being overweight or obese, not being physically active, certain types of diets, having a low blood level of vitamin D, smoking, alcohol use. And you will agree that these are potentially amenable to changing lifestyle, though not always easy. But there are also factors that you cannot change, like being older, though as it was pointed out before, colorectal cancer is rising among people who are younger. A personal history of colorectal polyps or colorectal cancer, a personal history of inflammatory bowel disease, which I have got a lot of interest in, and you will hear later on in the context of IBD-associated dysplasia and cancer. A family history of colorectal cancer or adenomatous polyps, having an inherited syndrome. You heard a fair bit about it also earlier. Racial and ethnic background, having type 2 diabetes, and some curious ones, factors with unclear effects on CRC risk stated by American Cancer Society, such as night shift work and previous treatment for certain cancers, including radiation therapy. Night shift work is probably related to food and microbiome. So gut microbes has emerged rather recently as key players. Colorectal cancer, as was stated before, is the 3rd leading cause of cancer-related deaths and is driven by host genetics and environmental factors. But out of these environmental factors, bacteria has emerged as a major factor, especially the microbiome in the colon. Number of bacteria has been associated, but there has been very specific focus on several of these. And the 3 that are identified are Fusobacterium nucleatum, I often abbreviate it to call FN. Fusobacterium is generally considered an oral bacteria, but it is increasingly found in colorectal cancers. Enterotoxigenic Bacteroides fragilis, and Colibactin producing E. coli. These have been increasingly associated with human CRC, and a lot of research going on in this area. Now, you remember that bacteria and cancer is not a new story. I mean, you all remember the story of Helicobacter pylori and the dramatic effect it had on the global prevalence of stomach cancer after eradication of Helicobacter pylori by antibiotics, but also by improvement of living conditions. Colibactin producing E. coli expresses a genotoxin that induces a specific mutation, and the signature is found within genomes for human CRC tissues. The enterotoxigenic Bacteroides fragilis and FN, Fusobacterium, shape the pro-inflammatory and the pro-tumorigenic immune environments in the GI tract, or within what is called TME, the tumor microenvironment. And this has become a very rich area of research. And one of the reasons I'm increasingly getting into it, because the microinflammation in the TME is related to bacteria and probably drives adenoma development or adenoma progression. FN encodes no obvious toxin, unlike E. coli, that might influence such immune response. And I will talk a little bit about how it might do so. But this is a dramatic picture about 6 years ago, which was published in Nature Medicine, showing with immunofluorescence a biofilm of these 3 bacteria that I just spoke about. You can see colored green, magenta, and blue. And these biofilms really shape the tumor microenvironment in some of these cancers. As you know, close to 90% of colorectal cancers are considered to be sporadic rather than inherited or predominantly genetic. So this is a very elegant study from Wendy Garrett's team in Boston, in Harvard, who showed that microbiome-derived short-chain fatty acids in the mice model. And what they showed is that if you have got a fusobacterium of a particular strain 7.1, as you can see on the top and the bottom bar charts, then the short-chain fatty acid levels, acetate, propionate, and butyrate, increase in the presence of fusobacterium. And on the bottom bar chart, it shows that this particular strain of bacteria, there are many strains of fusobacterium, they also increase the inflammation by driving a transcription factor called rho-gamma T, which drives a specific subpopulation of T cells, which are the Th17 cells secreting IL-17. And this is a very important inflammatory, tumor microenvironment cytokine that is attracting a lot of attention because it is potentially targetable. And you can see on the right-hand side, there are bar charts, but the most important message from them is that the free fatty acid receptor 2, FFAR2, this is needed for this particular signaling of IL-17. And this plays a part in this overall picture of IL-17 mediated inflammation and potential transformation and progression of colorectal neoplasia. Now, this kind of is a summary of what happens. You can see on the left-hand side, GM stands for gut microbiome, and there are the good ones that are good for gut microbiome, like dietary fibers, plant-derived phytochemicals, extra virgin olive oil, or omega-3 polyunsaturated fatty acids. To some extent, probiotics, though more focus is on prebiotics at the moment, or postbiotics or symbiotics. On the right-hand side are the bad guys, which disturb the gut microbiome and damages it, such as having a low dietary fiber, which has got the most attention epidemiologically and experimentally. Processed food, which is a really phenomenon of post-industrialized society. It has got a lot of attention also on inflammatory bowel disease. Red meat, which is always epidemiological observation. Obesity, smoking, alcohol, and a repeated antibiotic use, which damages the microbiome. A good, healthy microbiome provides host benefits, as you can see, and it revitalizes the enterocytes, improves mucosal integrity, and restores gut barrier function, and suppresses pathobiomes, the so-called pathogenic organisms. Whereas the oncogenic effects can be due to microbial factors such as microbial, what used to be called dysbiosis, we don't particularly like this term much, or carcinogenic metabolites or genotoxic substances such as the E. coli colibactin, which is genotoxic. And also mucosal damage, chronic inflammation, for example, oxidative stress, anti-apoptosis. Apoptosis clears the precancerous cells, angiogenesis, and epigenomic alterations. So this is a cartoon I have taken from a nice review article, and it very clearly illustrates the link between the microbiome, the diet, and colorectal cancer. On the left-hand side is the healthy diet, and the healthy diets are, as we know at the moment, are dietary fibers, plant-based phytochemicals, phytomolecules, polyunsaturated fatty acids, and extra virgin olive oil, and the so-called symbiotics, which are mostly prebiotics, like a beta-glucan, which is from seaweeds and other plant-derived areas. And then on the right-hand side is the at-risk diet, where the big warning signal is on red meat, and usually fish-based diet, definitely, if anything, protective. A high-fat diet is unhealthy, and dietary emulsifiers damages the mucin layer covering the mucosa, or low dietary fibers with poor microbial diversity. And this poor diet relates to forming biofilms on the mucosa, many of them containing especially those 3 bacteria I spoke about, or specific strains of bacteria, and eventual small areas of inflammation leading to transformation into adenomas and then carcinomas. So this shows the progression of these from chronic inflammation to cancer initiation to cancer progression. Each of these steps requires certain elements of these triggers, and especially Bacteroides fragilis, Fusobacterium, and E. coli of specific strains I spoke about are involved in these, with number of steps that are outlined in the middle of this figure. And this is now increasingly a focus as to, can we change it? Can we modify it by lifestyle change or by therapies? So this is a very exciting study. There have been a few like this. This one has been one of the nicest studies done, where from colon cancer patients, their microbiome was transplanted by fecal transplant to APC mice, the adenomatous polyposis gene carrying mice. And you can see here that in the APC mice, where colorectal cancer related microbiome was transplanted, adenomas started to appear in their intestine. And you can see on the pie chart on the right-hand side, in the APC mice given colorectal cancer microbiota, you can see high-grade dysplasia, the blue area of the pie chart expanding. And you can also see a number of changes at a molecular level, especially in the Ki67 and apoptosis by tunnel stain. So, but some microbes are beneficial. There's a lot of attention on Akkermansia. The evidence is slightly conflicting, but Akkermansia is a commensal inhabiting the human intestinal tract. It is a major producer of the good bacterial short-chain fatty acid, propionate, which is endowed with anti-inflammatory properties and can be linked to prevention of colorectal cancer. But what was very interesting in this paper, and the reason I'm showing this, is that Akkermansia mucinophilia was strongly upregulated in fasting volunteers. It was quite severe fasting. They had to fast for 16 hours, but that actually allowed the Akkermansia to spread. And that is beneficial potentially to colorectal cancer. And they even came up with a provocative suggestion that patients at risk of colorectal cancer, such as patients with inflammatory bowel disease with a history of neoplasm, may benefit from intermittent fasting. That I think we can debate, but it's certainly a very interesting study about how the field is moving. So this slide shows the short-chain fatty acids and polyamines, especially short-chain fatty acids, with their beneficial effect on cell proliferation and cancer. This is via kind of producing beneficial cytokines like IL-22, for example, and some of the amino acid-derived polyamines probably do the opposite. This is a kind of a summary of that. showing that short-chain fatty acids, probiotics, polyphenols like those from grapes, red wine, things like that, they do affect the cell proliferation, they reduce inflammation, they phagocytose the cancer cells, they reduce metastasis and reduce angiogenesis. These are mostly animal experiments, and we still have to see their effects on humans comprehensively via trials, but some of the epidemiological data are in favor of it. So this is another dramatic picture about how do we deal with bacteria if some specific bacteria are responsible in certain niches of the colon to progress or develop adenoma and adenocarcinoma, and whether bacteriophages can be the answer. Bacteriophages are virus, and there are more bacteriophages in the colon than even there are bacterial species. There are some millions and millions of viruses making up the virome. And these virome-specific bacteriophages can address and actually attack bacteria like Fusobacterium, E. coli, or Bacteroides fragilis, and actually lyse them. They can get rid of it specifically from their occupying their niche in the tumor microenvironment. And this is considered to be one of the ways to kind of start to target this bacteria, because giving them broad spectrum antibiotics like Helicobacter treatment, apart from the fact that we don't know which combination of antibiotics to use, will damage the microbiome pretty severely. So modulation of the cancer treatment by gut microbiome has attracted a lot of attention, both for chemotherapy to enhance the anti-cancer efficacy, but especially for immune checkpoint inhibitor therapy, where it has now been shown that you can modulate the microbiome by stuff like polyphenols, for example, or fecal microbial transplant as well, to increase the efficacy of these drugs. And this can also restore some of the so-called dysbiosis induced by pelvic radiation, relevant for prostate and also for some rectal cancers, as you heard. So we are getting to the final. So this is a carpet painted. It looks very pretty, and that's why I'm showing it, of a summary. On the left-hand side is the homeostatic situation, where the bacteria are generally the beneficial, healthy bacteria, and they are conducive to intestinal barrier function integrity and cellular integrity. Whereas once you get to tumor initiation or progression, you have bacteria that are potentially genotoxic, or they can produce inflammatory changes that can drive inflammation. And the best example, of course, of that is inflammatory bowel disease, but that's a different thing. That's a widespread condition. This is more localized, and in the worst case scenario, they form a biofilm on top of the epithelial layer, which is thought to be conducive to forming local adenomatous changes and progression to carcinoma. But a huge amount of excitement in anti-tumor response and therapy options for bacteria, not only for immune checkpoint blockade, which I spoke about, but the excitement about bacteriophages being specifically used to target these bacteria. So the future is very exciting, but the research is quite massive, and I have become very excited by coming to Cork and getting the chance to work with some world famous experts over there in this field, translating some of these things. So I will summarize now. So colorectal cancer is one of the most common cancers, you know that. That's why we are having a symposium. Globally, it ranks third in incidence and second in mortality among all cancers. It is a problem in Jamaica. The gut microbiota comprises a large population of microorganisms that interact closely with the host intestinal cells and can affect the immunity and metabolome in gastrointestinal tract. This is just as true for cancer, I think, in at least some cancer, as it is true for inflammatory bowel disease and other conditions like non-alcoholic fatty liver disease, etc. So in bold, the gut microbiota is involved in CRC formation. It is part of the story. It may not be the whole story, but it is part of the story and is involved in progression and is response to treatment as well, which is very exciting. It's an approach to personalized therapy. Substantial changes in abundance of specific bacteria can be detected in patients with CRC, that has been shown, and might serve as biomarkers for disease progression, which is also very interesting. Prognostication and prediction of treatment response. So again, aiming towards precision medicine. Modulation of the gut microbiota is a promising strategy to enhance treatment efficacy and reduce adverse effects of CRC therapies. But not only that, for reducing adverse effects of other cancers, such as melanoma, non-small cell lung cancers, and their response to immune checkpoint inhibitor. So finally, future research should look at the best ways to modulate the gut microbiota and to investigate the short-term and long-term benefits through clinical trials. And thank you for your attention, and I'll be open to take a few questions. Thank you.
Thank you very much, Professor Gosh. I mean, I do share your enthusiasm about this area of the gut microbiome. When you think about the surface area that's available to the environment and the fact that the GI tract is designed to actually absorb a lot of these interactions, more so than any other surface on the body. And once you throw the microbiome into discussion of any disease in particular, you can come up with some kind of interaction. So it's really an exciting area to go into, and obviously you're a leader in this field. I do have a few questions I will take from the chat here. I see, do you foresee any significant changes to the epidemiology of colorectal cancer in the medium to long term, given the likely changes in the gut microbiome after COVID-19 infections?
So that's a very interesting question. So you are totally right that there is increasing evidence that there are COVID-19, post-COVID-19 gut microbiome changes. We are also looking at this phenomenon in the long COVID situation, several months after people recover from COVID-19. On the patterns that we see, they don't seem to involve particularly the Fusobacterium strains that are been associated with it, and nor does it show changes in the genotoxic colibactin-producing E. coli. But who knows? I think we'll have to see this. I must say that the kind of the never seen before pandemic has focused a lot on the many aspects of the disease, including the gut microbiome. It is likely that we see similar microbiome changes for other infections, short-term antibiotic use, for example, which has been associated with colorectal cancer if they're used repeatedly. And these all play a part. Regarding epidemiological changes in colorectal cancer, I think the biggest change, overwhelming every other change, has been certainly in countries like UK, where there is a national program for colorectal cancer screening, which is free at the point of care. And this is also true for most European countries, and they have seen dramatic changes in colorectal cancer incidence. And that, I think, makes it very difficult to make any epidemiological studies on it, because you have to almost study people who have not been subjected to screening to kind of note it, because otherwise the signals of screening kind of almost overwhelms everything. But there's also the rather interesting creep, at least in some countries, not in every country, of a younger and younger onset of colorectal cancer. And one wonders whether this is related to changes in the microbiome because of increasing use of processed food, especially in young people, the wide spread use of various factors that almost inevitably come with a post-industrialized world that we have become used to. And we'll have to see that. I think that microbiome-targeted therapies initially will focus on whether we can make people who have got colorectal cancer, which has a record and is requiring, say, chemotherapy, as to whether we can improve the efficacy of chemotherapy by modulating the microbiome. That's where the biggest focus at the moment is. Altering the tumor microenvironment through bacteriophage intervention and things like that are still very much experimental, but we'll have to see this. You know what, I mean, at the end of the day, I mean, look what Helicobacter eradication has done for stomach cancer across the world.
Thank you very much. Another question here about acute appendicitis. Do you think it increases the risk of colorectal cancer?
The evidence is not very strong there. I think we are actually looking at appendiceal cell biology at the moment. I think there's a stronger connection with appendicectomy of an inflamed appendix and protection against ulcerative colitis, and then obviously that protection reduces colorectal cancer. But otherwise, the evidence is not very strong. It is very difficult to do epidemiology of appendicitis. It's a bit like many other things where there are so many people who actually have that event that the possibility of accidental associations and biases are very strong. And colorectal cancer is got numerous associations, and some of them are kind of probably not real associations. I don't think appendicectomy is a real association.
You did mention that dysbiosis was a term which you kind of have been frowning upon. Do you want to expand on that? And what alternative term should we be using?
Yeah, I kind of learned it after I moved to Cork, because the dysbiosis word is very widely used, there's no doubt. But it is very clear that in the world of a card-carrying gut microenvironment specialized microbiologist, they feel dysbiosis is, and I agree, is too vague a term and potentially simply is built on stool metagenomics, as you know, with the 16S or shotgun metagenomics, and showing that dysbiosis represents a different situation than a healthy microbiome. The biggest challenge is it is very difficult to define what a healthy microbiome actually is. There is a huge amount of global variation in healthy microbiome. And when we did our IBD studies, it was very clear that in different parts of the world, there was a huge variation in IBD microbiome. And they were all kind of microbiome there. And whether they're unhealthy or healthy is very difficult. So we find it difficult to ascribe the term dysbiosis, which indicates an unhealthy microbiome, without being able to quite define what a healthy microbiome is. We know that some of the bacteria represents potentially pathobiomes, and this is some of the strains of Fusobacterium nucleatum, some of the strains of E. coli, as I said, and Bacteroides. So it is easier to talk in terms of specific strain and go to strain-specific level than talk about the global microbiome derived from stool analysis.
Thank you very much. I have a question here about colon cleansing. So do you think a mild colon cleanse is a recommended thing in a person with a healthy diet, or is it recommended at all?
I do not think that colon cleansing, it was talked about a while, but I do not think there is any strong evidence for that. So I don't recommend that to anyone. What is interesting is whether, as a part of healthy dietary regimen, intermittent fasting has a role. And I gave you a little teaser on that with Akkermansia. Now, the experiment they did was a pretty strenuous experiment, 16 hours of fasting. Nobody's going to do that. And but there is a lot of evidence that metabolically we benefit from intermittent fasting. And so given that short-term intermittent fasting has no health detrimental effects, and if it permits some of the beneficial bacteria to regrow, and Akkermansia is now everywhere. It is associated with IBD, so colon cancer has a beneficial effect. That is okay. So, but I wouldn't actually go for colon cleansing. There is a lot of pseudoscience in colon cleansing, and a lot of practitioners in colon cleansing who practice that pseudoscience. And I have actually seen, as a result of some pretty vigorous colon cleansing, including use of rectal instrumentation, that resulted in pretty bad outcomes. And I know those patients personally. So I wouldn't recommend colon cleansing. Feel free to do some mild intermittent fasting, and then stick to the healthy diet. I think that's the most important part of it, I think.
At some point, someone has always commented that we're not quite sure what the normal microbiome is. And so we should not be basically trying to change it without understanding exactly what the components are. How close are we to understanding what the full microbiome is? And is it as unique as a fingerprint to individuals?
To some extent, it is true that it is a fingerprint. But the way we define normal microbiome, though we hardly can define it, is essentially whether the microbiome for people who don't have a specific disease is different from somebody who has a specific disease, like say ulcerative colitis or Crohn's disease. And to what extent in those diseases, the inflammation itself changes the microbiome as opposed to causative factors in the microbiome can be difficult. But on the other hand, because those are derived from population-based metagenomics, either 16S or shotgun, they are very deep dive microbiomes. And but on the other hand, looking at some of the beneficial elements of what really favorably affects the gut, so that we have a predominance of, say, bifidobacteria, Akkermansia, Roseburia. Those are actually healthy bugs, and they definitely actually promote a barrier function improvement, damping down on inflammation. And that is where I think giving dysbiosis as a all-encompassing term makes it difficult. But there's no doubt that if we talk in specific terms, that taking soluble fibers or even insoluble fibers, taking fish, for example, polyunsaturated fatty acids, extra virgin olive oil, improves many of these bacterial flora to expand in our gut. And some of them with a lowering of fat and increasing extra virgin olive oil and polyunsaturated fatty acids change the microbes dramatically within 1 or 2 days. They don't take days and days to change. These are actually some of the ways that we need to understand this. And if we try to kind of focus on changing the entire microbiome, that may be not only difficult, but it is probably going against our own fingerprint of microbiome.
Thank you. I see a hand up in the chat as well, Gloria Campbell, but I'm not sure if there's a question to be asked by Gloria. Moderator, can you unmute her if possible, if there's a question there? Once we wait on Gloria Campbell, perhaps.
A message, pardon me, Chair, a message was sent to her.
Yes, go ahead.
A message was sent to her to
Okay, I see. And she has not done so as yet. All right, perhaps if she's able to do so, we can acknowledge and take the question. Professor, I noticed that there's been no talk of funguses in regards to the microbiome. Is it purely bacteria that we think exist, or we're just not sure what the fungal?
Yeah, I kept away from fungi today and the virome today as well. Viromes are, first of all, they're difficult to study. We have been studying virome at the APC for many years in the context of IBD, and it has been difficult to actually have what I would call a beneficial footprint that we could identify that we can use bacteriophages for treatment of it. Fungi, these are important, but the evidence is not very clear. I mean, fungi can form a biofilm as well, but the evidence is not very clear. The difficulty of studying, well, it is a challenge for microbiome studying as well, but the biggest difficulty of studying fungi and virome is, well, first of all, the sheer diversity of virome is very difficult because viromes are associated with bacteria. They are kind of they go together hand in hand, except there are much more viruses than there are bacteria. Fungi to some extent, but the diversity of the fungome, which we can study with the shotgun metagenomics and we get the signal, is even more than the microbiome, generally speaking. So one of the real challenges has been that studying the entire metagenome globally has been very difficult because the geographical variability is massive, and that makes it very difficult. And mice models, where a lot of the evidence has been obtained from, are not ideal for studying fungum, for example.
Thank you very much. If there are no other questions, I'd like to thank you again, Professor, for accepting our invitation and giving us this interesting lecture today. And we would post. There is a question here: is adding yogurt to the daily diet beneficial? So, question on yogurt.
Yeah. So there's a lot of interest in yogurt, and there's a huge industry in healthy yogurts, as you know, and it's a massive interest in it. We feel that if yogurts have got positive health benefits, they're mostly in the ileum, not in the colon. That is our thoughts. And so we are studying some of the, especially commercial yogurts, in the small intestine, especially in the ileum, but we don't focus too much on the colon for that. Maybe we are wrong, but we haven't done it.
Okay, thank you. All right, so let's see if this is a... Okay, yes, thank you very much, Professor, for accepting our invitation and for giving us this talk today. So if you can stick around for the rest of the symposium, we welcome your company. So,
thank you very much.
Thanks.
It's been my pleasure.
All right, at this time, I would like to take the opportunity to acknowledge our sponsors again. So again, Casey Pharmaceutical, Abbott, AA Lakis, and Apex Radiology have all been integral in today's proceedings. Our next speaker is no stranger to us at the Cancer Society's colon meeting. In fact, he did not send us a CV this year because he assumed that we were so familiar with him. Dr. Patrick Roberts is a surgical oncologist and hepatobiliary surgeon at the Department of Surgery, Radiology, Anesthesia, Intensive Care section at the University Hospital of the West Indies and is a lecturer in surgery at the Mona campus. He is a graduate of the DM surgery program there and did his oncology surgical training with hepatobiliary focus at the University of Toronto in Canada. And he's no stranger to us here, and we welcome him today to give us a very specific talk, but again, very well connected to our symposium topic today. He's going to speak to us about Lynch syndrome in a Jamaican cohort. So please, Patrick, the floor is yours.
Thank you for that kind introduction, Mike. Just verifying if you are seeing my screen.
Not yet.
No, not yet.
Oh, Lord. Are you seeing it now?
No.
Okay. All right, let me try this again. My apologies there. Are you seeing it now?
We are indeed.
Okay, perfect. All right, sorry about that. Thank you very much. Thanks for that kind introduction again, Mike. So this is normally the hardest part of giving a talk for me, to tell you that I have nothing to share. Makes me feel a little bit worthless, And I do hope that in the future, I will have something to some form of conflict of interest, but I have no conflict of interest at the moment. So my outline for my talk is about Lynch syndrome. And I want to talk to you about the history of Lynch syndrome, the genes associated with Lynch syndrome, the diagnosis of Lynch syndrome, surveillance of Lynch syndrome, and to discuss a few interesting local cases that we have managed recently. It is always my view that when we think about Lynch syndrome, we think this is a North Atlantic disease or a Caucasian disease, especially for us in an Afro-speaking Caribbean country. And I think this has to do with the history of Lynch syndrome. This all started in the 1840s when a German man migrated to Michigan in USA, and he died in 1856 at age 60. And he had 10 children, 7 of which died from cancer. By the 3rd generation, he had 70 members in his family, and 33 of these 70 members had cancer. By the 4th generation, this family history was brought to Dr. Aldred Warthin by his seamstress. And Dr. Warthin did some work on this family and reported in 1913 that in certain families, there's an inherited susceptibility to cancer. Subsequent to that, Dr. Warthin died, and his work was carried on by Dr. Henry Lynch, predominantly in the 1960s, and it is a work of Dr. Lynch that really gave us some good idea about Lynch syndrome. And to honor Dr. Henry Lynch and his work, the syndrome was named after Dr. Henry Lynch. And this is actually a picture of Dr. Lynch and Dr. Warthin. But Lynch syndrome is due to mutations in the mismatch repair genes. And commonly there are 4 genes involved: MLH1, MSH2, MSH6, PMS2. But there can be other rare genes such as EpCAM and LRRFIP2. And essentially, these mismatch repair genes are responsible for correcting mistakes that are made during DNA replication. And if not corrected, then the protein that is going to be produced by this DNA could essentially behave totally different from the protein that is expected to be produced. And these tumors that can result as a result of the errors in the DNA sometimes can demonstrate what we talk about as a microsatellite instability. So these are the genes commonly responsible, and MSH2 is responsible for about 40 to 50% of Lynch syndrome, and MLH1 can be about 30 to 40 to 50%. And as you can see, the rare genes is going to be EpCAM and the LRRFIP2 gene. Now, these genes are inherited in an autosomal dominant fashion. They can be inherited from either the father or the mother. And the penetrance is going to be related to the gender, the age, and the gene. And the expressibility is going to be variable. You can have that rare situation where the mismatch repair genes can be inherited from both parents. And that is called a constitutional mismatch repair deficiency. And this is very rare, but it gives you an aggressive and extreme form of carcinogenesis. And these persons normally die at a very young age from cancer. The cancers that can be associated with Lynch syndrome commonly include colon cancer. And the second common is endometrial cancers. You do have other cancers that can be associated with it, but not as common. But I want you to pay attention to this one, which is the sebaceous tumor of the skin, only because later on, this is one of the cases that I'm going to show you when we reach the case discussion. So to make that diagnosis of Lynch syndrome, we normally need a detailed personal and family history. And sometimes we try to put this family history into the Amsterdam criteria or the Bethesda criteria, which I'll discuss later on. In addition to that, we normally want to do testing, and the testing can be done to the tumor, where we do immunohistochemistry or microsatellite instability testing, or it could be a germline mutation germline mutation testing to see if this person has inherited a gene from their parent. And rarely we may have to do somatic testing, which is another form of testing done on the tumor, also called genomic testing. So a lot of us would have been familiar with the Amsterdam and Bethesda criteria for medical school. And essentially in the Amsterdam criteria, we're looking to see if there are numerous tumors in this family associated with Lynch syndrome, colon cancer, endometrial, small bowel, etc. If there is colon cancer in the family, if these persons have developed, if there's at least one person in the family with colon cancer below age 50, diagnosed before age 50, and if other causes of cancer below age 50, such as FAP, have been excluded, if the cancers affect 2 or more successive generations. And the Bethesda criteria, which is commonly confused. Most persons assume that Bethesda criteria is to diagnose Lynch syndrome, but Bethesda criteria was actually meant to determine if you need to do microsatellite instability testing in a particular person with cancer. The problem with the Amsterdam criteria and the Bethesda criteria is that both lack sensitivity and specificity. The sensitivity for the Amsterdam criteria is 22% with a specificity of 98%. And the sensitivity for the Bethesda criteria is 82% with a specificity of 77%. So to use these 2 criteria to make the diagnosis of Lynch or to screen is a problem. And oftentimes when combined, about 25% of Lynch syndrome can still be missed. And in 2009, a workshop was held in Jerusalem. And at that conference, it was recommended that all persons with colon cancer below age 70 should have immunohistochemistry screening, just for the simple reason that trying to use either the Bethesda or the Amsterdam criteria, we're still missing a quarter of patients with Lynch syndrome. Now, immunohistochemistry, which Dr. Thompson could better explain than I do, is essentially using special stains to test the tumor, looking for the presence or absence of proteins that can be associated with. So if, for example, the gene that is responsible for a particular protein, in this case, MSH2 gene, is absent, then the protein that is going to be produced by that gene is going to be absent, and stains can show the absence, and that is where we'll be able to tell. And later on, we're going to show you some cases that we would do immunohistochemistry testing for. MSI testing, which stands for microsatellite instability, uses the PCR technology, which a lot of us would have heard about in the past 2 years. And to put it very simple, we're essentially comparing normal tissue to the tumor tissue to see if this microsatellite instability is present. But as it relates to colon cancer and Lynch syndrome, since this is a colon cancer conference, colon cancer and Lynch syndrome tend to have an early age of onset. It's average 45. And the location of this cancer tend to be predominantly right-sided. And as a result of that, certain methods of colon cancer screening, such as flexible sigmoidoscopy, would not be ideal. The ideal method would be a colonoscopy because you need to evaluate the right side of the colon. In addition, the colon cancer that you get in Lynch syndrome, you commonly get synchronous colon cancer around 10% of the times. And you can develop additional colon cancer in the future. And you also get extracolonic cancer, commonly in females, that is going to be endometrial cancer. The average risk for colon cancer in the general population is around 5.5%. But in someone with Lynch syndrome, this is around 80%. Similarly, in a female with Lynch syndrome, the risk of endometrial cancer is 60%, while in the general female population, the risk of endometrial cancer is 2.7%. So as you can see, having these genetic abnormalities in the mismatch repair genes can significantly increase your risk for some of these tumors. And screening guidelines that apply to the general or the average risk person cannot be used for persons with such a syndrome because of the significantly high risk of getting cancer. But sometimes our pathology colleagues are very kind to us. And if we look at the report, they may describe seeing features that may be associated with Lynch syndrome or MSI features. They may see things such as tumor infiltration lymphocytes, Crohn's-like lymphoid reaction, a medullary growth pattern in the tumor, if the cancer is right-sided. And here is a report, pathology report from Dr. Thompson, where he described in this patient of mine seeing MSI feature present. And he put the comment at the bottom, the patient's age and histologic features are noted. Mismatch repair protein status evaluation is warranted. And we're always very grateful for our pathology colleagues because It's a lot of information, which Lynch syndrome, which I'm going to try and condense, but most times, just in case you miss it, they will actually tell you that this is someone who you should at least do IHC testing or some form of testing, including genetic, because of the possibility that this patient could have Lynch syndrome. As was explained to you earlier, most colon cancers will occur from adenomas, and we talk about the adenoma carcinoma sequence. The commonest form is going to be a sporadic cancer. But conditions that give you lots of polyps, such as FAP and NAP, can also give you colon cancers. But these cancers tend to be microsatellite stable. The type cancers you get in Lynch syndrome are coming from adenomas, but it's going to be microsatellite instability. But just to clarify, though microsatellite instability on the pathology report may suggest to you to do testing for Lynch, the commonest cause of a microsatellite instability colon cancer is going to be a sessile serrated polyp that has transformed to a cancer. So most persons who have a microsatellite instability high, when you do the testing, will actually not have Lynch syndrome, because a sessile serrated polyp, as I was explained to you earlier, is the commonest cause of this type of microsatellite instability. It is important, however, for us to determine if someone with colon cancer has microsatellite instability, because this is going to be predictive if this colon cancer will respond to 5-fluorouracil, which is going to be the backbone of most chemotherapeutic regimes for colon cancer. In addition, this may also predict the role of immunotherapy, such as pembrolizumab, and also this favorable prognostic factor may actually determine that this patient may not need chemotherapy. So there are numerous reasons for us to determine if someone has microsatellite instability and if this is due to Lynch syndrome or the other reasons causing microsatellite instability. As you can see from this, Lynch syndrome causing microsatellite instability is about 3%, while other causes, sporadic, is still going to be responsible for the bulk of it. So how do we diagnose Lynch syndrome? These days, we talk about a 3-dimensional diagnosis of Lynch or a 4-dimensional diagnosis of Lynch. But for simplicity, I will not go into the 4th-dimensional diagnosis of Lynch. Essentially, for you to make the diagnosis of Lynch syndrome, there has to be a germline mutation in one of the mismatch repair genes. But you can see that using that family history and doing the tumor testing for microsatellite instability or immunohistochemistry and putting it together with the germline mutation, which has to be positive, there are different permutations and combinations that we can get from these 3 areas to make a diagnosis of Lynch, and I'm going to show you that now. So situation number 1 is someone could have a strong family history meeting the Amsterdam criteria. When you do their testing, they have microsatellite instability, or they have a positive immunohistochemistry, and you have the germline mutation, which has to be present, and then you have a diagnosis of Lynch syndrome. The next situation, as you can see in this line, they may not, their history and family history may not fit into the Amsterdam criteria. However, when you test, they do have a microsatellite instability or a IHC positive, and the germline mutation, which has to be present. And yes, this person would have Lynch syndrome. Or look at the situation. They may have a family history positive for the Amsterdam criteria. Their MSI or IHC status may not be known. They have a germline mutation. And having that germline mutation would make them having a diagnosis of Lynch syndrome. Or look at this situation where they may not have a family history. The MSI, the IHC status may not be known. Their germline mutation is positive, and again, you have Lynch syndrome. So the 4 possibilities of you making that diagnosis of Lynch syndrome, germline mutation has to be present. For you to make the diagnosis of hereditary non-polyposis colon cancer syndrome, then you have to meet the Amsterdam criteria. The MSI status may not be known, but the germline mutation would have to be negative. If that germline mutation is positive, then that is not Lynch syndrome. I want you to pay attention to this one called a Lynch-like syndrome or likely Lynch syndrome. This is someone who meets the Amsterdam criteria. have a MSI or IHC suggestive of Lynch syndrome, but when you do the genetic testing, it is negative. So this person cannot be diagnosed as Lynch syndrome, but they may have features of. And this is going to be important because I will show you a case later on of that. Or this situation, which is called a tumor Lynch, where the family history is not suggestive of Amsterdam criteria, doesn't meet the Amsterdam criteria. The MSI is high, and you don't have a germline mutation. And this would be what we call a tumor Lynch. So at the end of this talk, I will show you patients who have met all of those criteria that we have managed in Jamaica. It is also important if you have someone with Lynch syndrome for you to know exactly what mismatch repair gene is responsible for this, because the potential surgical treatment of this patient might also be dependent on the gene. For example, if this is someone who has a MLH1 or a MSH2, then extended surgery is normally recommended for these patients. As opposed to someone who has Lynch syndrome, which are MSH6 or PMS2, then there's really currently no evidence to suggest extended surgery for these patients. Having this diagnosis of Lynch syndrome and knowing the genetic mutation is also important, not only for surveillance of the patient, but also for next generation surveillance in that family. For example, because we know the average age of diagnosis of colon cancer in someone with Lynch syndrome is 45, we actually want to start screening for colon cancer by age 25 or 10 years younger than the youngest person in that family with colon cancer. So for example, if you have someone with colon cancer at age 30 in that family with Lynch syndrome, you may actually want to start your colon cancer screening by age 20. And I will show you one such situation again in our case discussion. You want to do annual colonoscopy, as opposed to what you heard earlier on about average risk person and the duration. Because of the adenoma carcinoma sequence in someone with Lynch syndrome is accelerated, you may have to do this colonoscopy as often as annually. And again, we will show you one such case where within a year, our patient had another colon cancer. It's not just the colon that we need to do surveillance of, but we also need to do upper gastrointestinal endoscopy. Though this may not be as common as colon cancer and endometrial cancer, these patients are at risk for getting gastric cancers. And you need to screen for the gynecological cancer. Remember that endometrial cancer is the second most common cancer in Lynch syndrome. So they will need to do pelvic ultrasound. CA125 needs to be done. They would need to get endometrial sampling. And they also need yearly urinalysis because they do get urological tumors as well. It is important for you to do surveillance in patients with proper surveillance in patients with Lynch syndrome. We have evidence to show that the 10 and 15-year survival is significantly better for persons with Lynch syndrome who undergo proper surveillance as opposed to persons who don't undergo any surveillance. The 15-year survival for Lynch patients who have no surveillance program is about 74%, while with adequate surveillance, it's about 92% survival of 15 years. So it's very important for this to be done. But there are some state-of-the-art changes in the management of Lynch syndrome. And one is called the CAP2 study, and also the Ask2Me site, which I'm going to explain to you what those are. So in the CAP2 study, what this study has shown is that persons with a mismatch repair gene deficiency, if given 600 milligrams of aspirin daily, can have a significant reduction in the risk of colorectal cancer. Now, the obvious question that came out of this study is 600 milligrams of aspirin daily is a lot, and you can get some of the potential side effects from that. And there are now studies going on to see if a reduced dose of aspirin can have a similar effect. But we do know now that aspirin is a form of chemoprevention in persons with Lynch syndrome as it relates to colorectal cancer. Now, I do know that it's a lot of information as it relates to Lynch syndrome. But I want you to be aware of this side. All syndromes known to man evaluator. Any syndrome you're seeing in your practice, any patient with any genetic abnormality, all you have to do is to put the gene into this side, put the gender of the patient, put the age, And it can give you a graphical and a mathematical printout, which will make your discussion with the patient much easier if they're at risk for cancer, what cancer they're at risk for, and the percentage risk. So this is, so I do this regularly with my patients in my practice. And this is just one printout for one of my patients, 35-year-old female with a genetic abnormality in MSH2. And we're able to get a graphical representation of the cancer risk in the future. And I find that this is very important and helpful for patients to actually make the hard decisions they have to make sometimes. For example, do they go back and do a total colectomy? Do they do a oophorectomy? Do they do hysterectomy, etc.? Having this visual aid, I find, is very important. So let me start with case one, just to show you a few of these cases that we have managed recently. And this is of a 36-year-old male who presented with right upper quadrant abdominal pain. And the only person in his family with cancer was his father, who had stomach cancer at age 40. He saw his private practitioner, who sent him for an abdominal ultrasound. And based on the abdominal ultrasound, he was sent for a CT scan. And as you can see, the date of birth, just to show you that I'm not fabricating anything. And the CT scan was done. And pay attention to what the radiologist said. Mid-transverse colonic lesion with adjacent lymphadenopathy. Colonoscopy is advised. So his general practitioner sent him for a colonoscopy. And this is the colonoscopy report. Again, you can see 36-year-old male. And this is what was found: a polyp of the sigmoid colon and a transverse colon mass. And both lesions were biopsied by the gastroenterologist. And this is the histology from the biopsy done by the gastroenterologist, that the transverse colon mass was a colon cancer, moderately differentiated, and the polyp in the sigmoid cancer was also a colon cancer. This patient is 36 and is presenting at 36 with not one, but two colon cancers. So obviously this is going to raise our suspicion that this could be someone with Lynch syndrome. And obviously, if we should prove that this is Lynch syndrome, screening this person's family, we would want to start at least 10 years, if not even earlier, in other family members because of this early age of onset. The average age for Lynch syndrome is about age 45. So I took this patient to the operating room and I did a total colectomy. And as you can see, it's a large tumor, it's T3. And this is typical of Lynch syndrome. They tend to be very large cancers. But bear witness, we removed 56 lymph nodes and they were all negative. And that again is a common feature. And note the MSI features again described by the pathologist. So though this was a large bulky tumor, you could see that it was favorable from the extent that the lymph nodes were not involved. And as is true to our pathologists, look at the comment at the bottom. Genetic investigation for colorectal associated cancer syndrome, example Lynch, is strongly advised. So as we do with our patient, I sent this 36-year-old male, I sent his sample for immunohistochemistry. And this was the immunohistochemistry result, showing that he did not have the protein from MSH2 and MSH6. They were negative, they were not present, suggesting that these two genes may be defective. There may be a mismatch appearing in these two genes, and that's why he can't produce the proteins associated with these two genes. So the next step in this gentleman is to do his genetic testing. Remember I spoke to you earlier on about the three-dimensional diagnosis. So we had his family history. The only person in his family with cancer was gastric cancer, his father at age 40. So we're able now to put him into that Bethesda Amsterdam criteria. We have his immunohistochemistry here, which we're looking at. So the next thing is to do the genetic testing, because to make that diagnosis of Lynch, we have to have genetic testing. So I did his genetic testing, and here is his result. Again, he's 36. He was born in 1982. This patient was managed in 2019. And as you can see, he had a deficiency in the MSH2 gene. So we were able to make this diagnosis of Lynch syndrome in this patient, and we went on to screen all family members who were willing to accept screening. And obviously that screening came at no additional cost. The genetic testing for his entire family, unlimited amount of family members, is free. I want to show you this case number 2. This is of a patient I managed last year and continue to manage. And you will see from the dates that the story is unfolding. This is of a 71-year-old woman with a peanut-sized pimple to the left flank, which was getting bigger. She had no family history of cancer, never had a colonoscopy before. She went to her private practitioner, and her private practitioner excised the lesion. Private practitioner was an excellent doctor, so even though she excised it in office, she sent it to the pathology lab for assessment. And the private practitioner also took a picture of this lesion before excision, and this is the picture, and that was taken by the private practitioner. This sample was sent to the lab, and this is the report from the pathologist that this patient had a sebaceous carcinoma. If you remember at the beginning when I was showing you the lesions or the cancers associated with Lynch syndrome, I told you to pay attention to sebaceous carcinoma. This is a very rare cancer, and they can be extremely aggressive. And note that the pathologist also said that the margin was positive, meaning cancer is left back behind. So this patient was referred to me with this pathology report, and the GP was so kind to send a picture of of the lesion. And when I examined the patient, this was the site of the excision that was done by the GP. So I took this patient to the operating room, and we had to be quite fast with this because if you know anything about sebaceous carcinoma, they're very aggressive. And this area is looking blue because we injected around the surgical site with blue dye. And in addition, we injected the surgical site with some radioactive substance, technetium sulfur colloid. And we did a lymphoscintigraphy the day of surgery. What that is, this blue dye and this radioactive substance is going to follow the route that the cancer would take, and it would go to the very first spot in the body that this cancer would spread to. So this is the image of this patient. We're looking from behind. So the head is here. This is going to be the right hand. This is going to be the left hand. And you're seeing this bright area in the left axilla because we're looking from behind. And this is the very first spot in the body that cancer would spread to. So this is called a sentinel node. So we took this patient to the operating room and we did a wide excision of the area. And this is a specimen that was taken. Remember, the margin was positive from before, from the excision that was done by the GP. And we, in addition, removed that node that would be the very first spot in the body that this cancer would spread to. And we sent it to the lab. This was a report from the pathologist confirming what we knew from before, that it was in fact sebaceous carcinoma, that the margin was negative, so no cancer left back behind, and that this node that we removed from the axilla was negative, so the cancer did not spread. But note the comment here, and I can tell you who the pathologist was, Dr. Thompson, who presented earlier. He said, these lesions may be associated with the presence of another carcinoma or Moore-Torre syndrome. And if you know Dr. Thompson, what he's saying to us is that this sebaceous carcinoma could be very well be Lynch. That is what Moore-Torre syndrome is when you get a sebaceous carcinoma due to a mismatch repair deficiency. So as a result of this report from Dr. Thompson, we sent this patient cancer for immunohistochemistry. And this was the report. So as you can see, sebaceous carcinoma, and we tested it. And here we're seeing a deficiency in the MSH2 and MSH6. So this is suggesting to us that Dr. Thompson could very well be right. This patient seems to have Lynch syndrome. But though the IHC is suggestive of this, we need to do a germline mutation testing. We need to see if this lady inherited any of the autosomal dominant genes to confirm the diagnosis and to label her as having Lynch syndrome. And to my surprise, this is the result of the, I will show you the result of the genetic testing soon. Having taken the cancer out, we sent her for a colonoscopy. And this is the report from the gastroenterologist. A few polyps were seen in the sigmoid colon and the hepatic flexure. Those were removed and sent to the lab. This colonoscopy occurred 2 weeks ago, so we haven't gotten back the histology as yet. But the genetic testing was done, and this is my surprise. Again, she was born 1949, she's 75, the results negative. So if we had labeled this lady as having Lynch syndrome based on the cancer she had and immunohistochemistry, we would be totally wrong. And this is what we meant when we talk about a three-dimensional diagnosis. To make that diagnosis of Lynch, you have to have that germline mutation. So we could give this lady various terminologies. We could call her Lynch-like, we could call her tumor Lynch. There's so many other terminologies we could use, but we have no genetic abnormality in the mismatch repair genes. So we could not label her as Lynch. As you can see, we just got back this report, the 8th of March, 2022. So we still have some additional work to do with this lady, and we're awaiting the results of the polyps that were removed from colonoscopy. Here is a third case, and this is of a 45-year-old lady. Remember, the average age of diagnosis is 45. And this lady presented with blood in her stool. The only family history of cancer was her mother, who had breast cancer at age 70, and a maternal aunt with breast cancer in the 50s. So her GP, because of this blood in the stool, sent her for a colonoscopy. And this lady had her scoping done by one of the gastroenterologists on this forum. As you can see, she's age 45. And also that this colonoscopy was done in 2020. I think it was December 2020. It's important for you to follow the dates because of where the story is going to. And as you can see, the indication, abdominal pain, PR bleeding, and diarrhea. And at colonoscopy, a lesion was seen about 20 to 25 centimeters from the anal verge. And this large sigmoid mass was biopsy. The gastroenterologist, as you can see from the picture here, thought that this mass looked malignant and a biopsy was done. And this is the histology from the biopsy. Again, 1975, she was born, age 45. As you can see, this was December 2020. You will need to follow the dates for this case. And here, the specimen from the sigmoid colon came back as a moderately differentiated adenocarcinoma. So we took her to the operating room. We did a sigmoid colectomy. We had no reason at that time to think that this person had Lynch syndrome. We discussed genetic testing. She didn't want to do any genetic testing at that time, and she was not interested in having anything else than her sigmoid colectomy, which we had no evidence to do anything other than that. So as you can see, the surgery was done February 2021, the 4th of February. Again, the date of birth, 1975. And this is the pathology report. Again, look at the size tumor. It's a big tumor. It is T3. Again, the nodes that were removed were negative, and the pathologist spoke about the MSI features. So because of this report from the pathologist saying that MSI features, we were now able to send this tumor for immunohistochemistry. And here is the immunohistochemistry report saying that the cancer was deficient for the PMS2 proteins, which is suggesting that this person may have Lynch syndrome. So she was sent for a repeat colonoscopy. As you can see the date here, this was done January of this year, 2022. And to my surprise, at this repeat colonoscopy, the gastroenterologist saw this lesion 10 centimeters from the anal verge, and also saw an error at the biopsy, at the anastomosis that I did, and the gastroenterologist biopsied both lesions. To just give you the backdrop of this story, this second colonoscopy was done by a different gastroenterologist. The first gastroenterologist took about 40 pictures. So we had pictures of the entire colonoscopy, and with the scope retroflex. So we had pictures of this area that was being seen now. And here we have this colonoscopy from a second gastroenterologist, now seeing a lesion 10 centimeters from the anal verge. And we were able to look back at the previous colonoscopy and nothing was seen in this area. So if you notice, within 1 year, this lesion is now arising 10 centimeters from the anal verge, which makes the point that I was saying that sometimes doing this colonoscopy as early as a year can be important for surveillance. So if I wasn't suspicious that this person had Lynch syndrome, maybe it wouldn't have been done so early, even though that is the recommendation if you have a colon cancer. So this is the histology from that lesion from the 10 centimeters from the anal verge, and it was an adenocarcinoma. The lesion seen at the biopsy site, at the anastomosis site, was inflammatory polyp, and Dr. Thompson spoke about inflammatory polyp. So within the space of 12 months, this lady was diagnosed with another colon cancer. So we sent her for genetic testing, and to my surprise, it was negative. So we cannot label this lady as Lynch, even though she's behaving like a Lynch syndrome patient. So at best, we could call her Lynch-like. But just to introduce the fourth dimensional testing, because I'm still suspicious that this lady has Lynch syndrome, What I'm going to do, and if you notice the date on this genetic testing, it is in 2021, it was in November. What we're doing now is to do testing on the tumor, which is a somatic testing or genomic testing. We're actually testing the tumor itself to see if there is any gene deficiency in the tumor. And that is what we talk about, a fourth dimensional diagnosis, which we're not going into today. But just to let you know that we do all of these things for our patients in Jamaica. And the last case I want to share with you, because I have to use different cases to make the point and the pictures of the multiple permutation and combinations that you can have, is again of a 45-year-old male who presented while I was on emergency duty at University Hospital with large bowel obstruction due to a rectosigmoid intussusception. We had to take him to the operating room, and we found a tumor in the area that was being seen on the CT scan, and I resected it. And again, bear witness, this is a very large tumor. It is a T3 tumor, very typical of Lynch syndrome. We removed 19 lymph nodes, and they were all negative for metastasis, though this cancer was so small, was so large. So we were very suspicious. He's 45. This is the average age that people would present with Lynch syndrome. So we sent this tumor for immunohistochemistry testing. And this was the testing that was done. Again, look at the age, 45 years old. And the testing showed that this patient was deficient for the proteins associated with PMS2. So we suspected that he had Lynch syndrome. But as you could see from the previous cases, having a suspicion based on IHC is not sufficient. We need to do genetic testing. And this was the genetic result for that patient, confirming, as was indicated by the IHC results, that he has a pathogenic variant in the PMS2 gene. So this patient was confirmed to have Lynch syndrome, and we have subsequently tested other family members and have implemented them, those that are positive, on a surveillance program. So what is our experience in Jamaica? Because oftentimes we think about Lynch and FAP and we assume that these are North American or North Atlantic diagnoses in Caucasian population, but they're very much here. In as early as 2012, Professor Plummer reported on 25 patients with colon cancer that were younger than age 40. And he tested those patients for MLH1 and MSH2. And he found 3 persons out of that 25 that were positive for Lynch syndrome. In my practice, over the past 2 years, I've tested 27 of the colon cancer patients that I've managed. Obviously, not everyone accepted genetic testing, but I routinely recommend genetic testing for everyone because of what is now recommended. And I tested 27 of colon cancer patients that I managed, and 7, which is 26%, tested positive. Now, obviously, this is not scientific. There are some obvious biases. Maybe why these 27 patients accepted testing is because their family history was probably stronger than some of the others. So I'm not presenting this to say it is scientific. I was just rarely sharing with you raw data from my practice. So I had 26%, or 7 of the 27 patients I tested in the past 2 years from just my practice alone tested positive. And of the 7, 3 had MSH2, 3 had MLH1, and only 1, which was the case I shared with you, the 4th case, had PMS2 gene present. So it begs the point that the Jerusalem workshop in 2009, at that time they were pushing for IHC to routinely being done. Now a lot of places are saying that these genetic tests are so cheap and readily available that we should now frog leap to doing this, because we know that the Bethesda criteria and the Amsterdam criteria, if we apply those, we're missing around 25% of patients. And at this point, I want to end my talk and I will be willing to accept any questions that may be there for me. Thank you very much.
Thank you very much, Dr. Roberts. So, if you can answer from the chat. I saw a question here from Gloria Campbell. She's asking about testing for family members. If there's a family member with cancer, what test is to be done to determine the risk for cancer?
Well, ideally, what we want to do is to take a personal and family history. We want to talk to that person before. We need to do some amount of counseling as to what this genetic test is and obviously the implications. I mean, if we do test you and it comes back positive, we need to make sure that you're mentally prepared for this. And sometimes, you know, though we may not be faced with those issues in Jamaica in terms of insurance company denying you insurance, but you know, the elephant in the room with genetic testing is always, you know, the potential for insurance company, etc. If they have access to this information, which they really don't, because your information is confidential. But could you be denied insurance, etc.? So you really need a pre-test counseling. How we do it in Jamaica, we the doctors will do the counseling, but we also have genetic counselors. We have numbers that we give you. After you have done the testing, you have a special number, and all you have to do is to dial this phone number and give your medical record number 24 hours a day, and you can get a counselor, a genetic counselor that will go through. They will have access to your result, and they will be able to go through that information with you. We're not suggesting that necessarily everybody with cancer needs to get genetic testing, but for sure, if you're seeing multiple family members and if the age is young, and because the test is so cheap now, we're doing it increasingly so, because there's just so much that can be gained. We do know that a lot of the times our family members are not our family members. I think the American Embassy has done a great job of demonstrating that in the Jamaican population. So sometimes, even if you know your family history, you can't really swear, especially on the paternal side. We know it's about 40% of the times, you know, the assignment of paternity may be wrong.
Interesting. Thank you very much. And someone is asking, where is this testing available, genetic testing?
You can get genetic testing at Cunningham Medical Services. It's saliva that we need, so we don't need to stick. You don't need to give any blood. We don't need to cut you or anything. It's just saliva. The cost is 60,000 Jamaican dollars, and that covers the entire family. So if you have 30 brothers and sisters, which is not unusual in Jamaica, and those brothers and sisters have kids, if you test positive, and if everybody come within 90 days, that $60,000 cover everybody. So we do have times when, I remember one family from Brownstone, it was a coaster that the family charter, and it was a family trip from Brownstone to get everybody tested, because they knew for years that something was wrong with that family. So many persons in the family had cancer, and it was only after the son got diagnosed with Lynch syndrome at age 32 and had a positive test, everybody could not be tested for free. And that is our first Lynch family that we found in Jamaica. And so many of those persons have gone on to get proper screening. Other cancers have been detected, and we haven't lost anyone in that family to date. So the cost is 60,000, Cunningham Medical Services, 11 Cunningham Avenue.
Thank you. I see a hand up from, is it Candice Campbell? I'm not sure if that's a hand for a question, but I'm going to ask our IT team to just check in with her. There's a question here for Professor Gosh from before. Prof, are you with us? There's a question about magnesium and constipation leading to increased colon cancer risk.
Yeah, I think there has been a story probably more like a couple of decades ago, and then a Swedish group did a proper study on that and found that magnesium supplementation, if anything, reduced the incidence of colorectal cancer rather than increase it. I personally interpret it as meaning that at least there is no extra risk of magnesium supplementation.
Thank you. Appreciate that. Dr. Roberts, for someone that has had stage 4 endometriosis, do you recommend they do the genetic test?
Endometriosis is not a cancer. So we don't do genetic tests routinely for endometriosis. I'm not sure if they meant to say endometrial cancer.
Perhaps.
If they meant to say endometrial cancer, because of the high association of endometrial cancer with Lynch syndrome, endometrial cancer is one of those cancers now that it is recommended that routine genetic testing should be done. Ovarian, endometrial, breast, colon, etc. So if endometrial was what they meant to say, which I suspect that's the case, yes. And especially if there are multiple family members with endometrial cancer. It can be 60%, the association with Lynch can be up to 60%.
Thank you. Okay, I'm not seeing any other questions at this time. So thank you very much, Dr. Roberts, once again for joining us this year. Really appreciate your interaction with this.
Thank you very much.
Okay, so our final speaker is the one lady among all the thorns. And we're very happy to have her speak to us today on colon cancer prevention and inflammatory bowel disease. She is a specialist in inflammatory bowel disease. And as I said before, all our speakers are linked. And by now you should be able to tell how they are linked. They are all trained in a certain country. She is a consultant gastroenterologist and internist at University Hospital in the Department of Medicine, and did her specialist training in gastroenterology in Ottawa, Canada, and is well qualified to speak to us today on cancer prevention and inflammatory bowel disease. Dr. Yvonne Dawkins, welcome, and please go ahead.
Good afternoon, everyone. Thanks, Dr. Mills, for that kind introduction. I would like to thank the organizers for allowing me to speak on this very important topic that's close to my heart of colon cancer prevention in patients with IBD. I just like to confirm that you guys are able to see my screen.
Yes, we can.
Okay, perfect. So, like most speakers, I have no relevant disclosures for this topic. And in terms of the areas that will be covered throughout the presentation, I'll be briefly looking at the global burden of colorectal cancer, both locally and globally and locally, the epidemiology of IBD-associated colorectal cancer, some of the risk factors, its pathophysiology, and the latest in terms of the updated guideline for colon cancer surveillance in IBD. Colon cancer, we know, is a significant global problem. It's the third most commonly diagnosed malignancy worldwide, behind breast cancer and lung cancer. And it's also the second most deadly cancer after lung cancer. In Jamaica, it's also a significant problem because it's the third most commonly diagnosed cancer in both male and females. And looking at the sexes for men of all ages, is the second most commonly diagnosed cancer, accounting for 13.1% of cancers diagnosed among men in Jamaica. And for women, it's the fourth most commonly diagnosed cancer after breast, uterine, and cervical cancer. Many risk factors for colorectal cancer. They're divided into modifiable and non-modifiable risk factor. And what I'd like to highlight is that inflammatory bowel disease is a known risk factor for colon cancer. So what is inflammatory bowel disease? It's a group of conditions that cause chronic inflammation in the gastrointestinal tract, and this inflammation is immune-mediated. It consists primarily of two disorders. There's ulcerative colitis, and then there's Crohn's disease. And there's a subset of patients, less than 5%, who have colonic inflammation, but it's unclear as to whether or not this is ulcerative colitis versus UC versus Crohn's. And so these individuals are assessed as having IBD undifferentiated. Now, for ulcerative colitis, the disease can be classified according to extent of involvement of the colon. If they have disease confined within 18 centimeters of the rectum, they're referred to as having proctitis. Once it extends beyond the rectum up to the splenic flexure, but not beyond, they're referred to as having left-sided colitis. Once it extends beyond the splenic flexure, then they're referred to as having extensive or pancolitis. Patients with Crohn's disease can involve anywhere from the mouth to the anus. And so this does modify the risk in terms of the development of colon cancer. Patients with ulcerative colitis as confined only to the rectum, their risk of IBD-related colon cancer is similar to that as the general population. If they have Crohn's colitis and it involves less than a third of the colon, then their risk is similar to that as the general population as well. In terms of the epidemiology for IBD-associated colorectal cancer, It accounts for 1 to 2% of all cases of colorectal cancer, and it is a significant cause of mortality among these patients because it accounts for around 10 to 15% of all cancer deaths. IBD-related colon cancer also tends to affect patients at a younger age. So around 40 to 50 years, they may be presenting with colorectal cancer as opposed to those with sporadic colorectal cancer who tend to present a little later at around age 60. And they also tend to have more synchronous lesions compared to those who have sporadic colorectal cancer. Over the last 30 decades or so, it has been clearly documented that the incidence of IBD-associated colorectal cancer has declined, and that is due to a combination of increased awareness of the association between inflammatory bowel disease and colon cancer, and the more systematic surveillance programs, as well as improved control of the mucosal inflammation, which, as we will see, is a main driver for the risk of colorectal cancer in these patients. Thank you. Now, an attempt to try and identify risk factors that modify the risk of IBD-related colon cancer, a number of systemic reviews and meta-analyses were conducted. And what has been found is that those who tend to have a longer duration of disease and more extensive involvement of the colon are at higher risk of IBD-associated colorectal cancer. Patients who have primary sclerosing cholangitis as well, this has been found to be a high impact independent risk factor for the development of colitis-associated colon cancer. Pseudopolyposis, as is demonstrated in this picture here, the pseudopolyposis, they actually represent areas of severe healed inflammation. So it's not like the pseudopolyps have malignant potential within themselves. It's actually what they represent, areas of severe healed inflammation. And as you can notice, these finger-like projections will also make it difficult to survey the affected areas for colon cancer, so it can hide dysplasia. And as a result of these two factors, pseudopolyposis has been associated with an increased risk of colon cancer. And also, a family history of colorectal cancer is also recognized as an independent risk factor. Now, there has been attempts to try and come up with different types of prognostic factors, or to identify all the prognostic factors associated with advanced neoplasia in patients with IBD. And so this recent systemic review and meta-analysis included 164 studies, and they looked at pooled data for 31 prognostic factors. Now, they defined advanced colorectal neoplasia as patients who have either high-grade dysplasia and or patients who have colorectal cancer. And they categorized the evidence for each prognostic factor into being either strong evidence, moderate evidence, or weak evidence. They were able to identify 13 risk factors and 5 protective factors. Of the 13 risk factors, extensive disease was the only one that was found to have strong evidence for an increased risk of IBD-associated colorectal cancer, whereas other factors such as low-grade dysplasia, primary sclerosing cholangitis, those who have UC, those with pseudopolyposis, a family history of colon cancer, and strictures were found to have moderate evidence supporting these risk factors. All the others were found to have very weak quality evidence. In terms of the protective factors, they identified 5, and thiopurines 5-ASA, as well as smoking, usually having to do with the anti-inflammatory properties, were found to have moderate evidence for reducing the risk of colon cancer, as well as surveillance. The use of statins, which I'll briefly mention afterwards, has been found to have some amount of evidence supporting its protective role in preventing colorectal cancer. For the pathogenesis of sporadic as well as IBD-associated colorectal cancer, both of them tend to be quite similar, with the similar molecular alterations occurring. But what is different is the timing and the frequency with which these molecular alterations occur. For example, most sporadic colorectal cancer, they arise from an adenomatous precursor lesion, and this progresses through the different stages of adenoma until they develop a carcinoma. And what is to note also is that these genetic alterations that occur, one of the first things that occur for sporadic colorectal cancer is that there is loss of APC function. And this is considered to be the crucial step which then drives the other molecular alterations that occur in sporadic colorectal cancer. And you'll notice that p53 mutations tend to occur later on in this adenoma carcinoma sequence. And at the end, there is an adenoma which is clearly visible and it's usually raised even at the time of standard white light endoscopy. Compare that now to patients who have colitis-associated colorectal cancer. So they tend to have this plastic precursor lesion, which progresses through the different stages of dysplasia, from indefinite dysplasia to high-grade dysplasia, and then carcinoma. And although the genetic alterations that occur in patients with colitis-associated cancer tends to be quite similar to those with sporadic colorectal cancer, you'll notice that the frequency and the sequence with which they occur is different. For example, you tend to have p53 mutations earlier on in patients with colitis-associated colorectal cancer, and loss of APC function tends to be a much later phenomenon, and it also occurs less frequently. But how this plays out in terms of development of colorectal cancer is that at the time of endoscopy, they tend to have lesions which are flat and the margins may not be as clearly distinct. And this actually does provide a basis or a justification for using augmented techniques to determine colorectal cancer, to detect colorectal cancer in patients with IBD. For example, as Dr. Thompson mentioned earlier, chromoendoscopy. Bearing in mind the pathophysiology, is there any way that we can prevent these patients from developing colon cancer? And of the several studies that have been done, the two main factors that seem to play the most significant role includes controlling the mucosal inflammation, as well as early and adequate surveillance for colorectal cancer in these patients. So for patients who have intermittent episodes or flares of their inflammatory bowel disease, that episodic inflammation is accumulative over time, and it is strongly associated with an increased risk of colorectal neoplasia. And it doesn't really matter how severe the inflammation is, as long as they have inflammation, that increases the risk of developing colorectal neoplasia, which is why an important endpoint in terms of managing patients with IBD is to ensure that we achieve not just symptomatic improvement, but we also need to achieve mucosal or endoscopic improvement so as to reduce their risk of developing colorectal cancer. And for surveillance, there are several guidelines, but one thing, and even though they have several differences, one thing that they will agree on is that surveillance colonoscopies should be performed more frequently in these patients than in those in the general population. Now, this particular slide is just meant to illustrate that over the years, there has been several different guidelines for colorectal neoplasia in IBD. And even though they may not agree in terms of the technique that's used to perform surveillance, they all agree that the interval should be shorter in patients with IBD. And so for the next few slides, what I would like to do is to just briefly review the latest recommendations as far as colorectal neoplasia surveillance is concerned in patients with IBD. And this guideline was just published in October 2021, and it looks at how endoscopic surveillance should be carried out, and once a dysplastic lesion is found, how we will manage that dysplastic lesion. So when do we start surveillance? Initial surveillance colonoscopy should be performed at 8 to 10 years after disease diagnosis in all patients with colonic IBD. But for those who have PSC, they should immediately start surveillance colonoscopy. And this 8 to 10 years actually came about from a previous systemic review and meta-analysis that was done much earlier on, which tried to look at the increasing risk of colon cancer as far as disease duration is concerned. And what they found is that the risk tends to be pretty flat until you get to around 10 years, where they notice that the risk of colon cancer it's increased. So around 10 years after disease onset, there's a 2% risk of having colorectal neoplasia, and it increases incrementally at around 8% at 20 years after having disease, and it goes up exponentially to around 18% in those who have had disease for 30 years. So based on this, which has also been found in other studies, it is recommended that surveillance begin at 8 to 10 years in those with colonic IBD. And at the time of the initial surveillance, colonoscopy, it can be used to restage both microscopic and macroscopic disease activity, as well as extent. And this can be used as a guide as to how often future surveillance should be carried out, as I will show in a few minutes. At the time of surveillance colonoscopy, you want to have optimal condition, or to increase your likelihood of picking up dysplasia that's actually there. So the patients should be in mucosal remission, meaning that inflammation should be controlled, because if they have active disease, it's difficult to detect dysplasia in that setting. So we want them to be in endoscopic or have achieved mucosal healing prior to performing surveillance. And as you can imagine, we need to see the lining of the mucosa, and so excellent bowel preparation is actually recommended, and the use of high definition endoscopes, which will make it easier to detect lesions as compared to a standard definition scope. And any lesion that is found, once it's clearly demarcated and there's no stigmata of a malignancy, then endoscopic resection can be undertaken at that time. What is recommended in terms of the technique to perform surveillance colonoscopy? So currently, it is recommended that high definition colonoscopes be used. As demonstrated here, you'll see that it's easy to see the vascular pattern. The surface of the mucosa is quite clearly visible. If there's any subtle mucosal abnormalities, it's a little bit easier to detect that as compared to the high definition scopes, as compared to your standard definition scopes. The high definition scopes have been shown to detect as much as around 90% of colonic dysplasia, compared to 80% for those who use standard definition scopes. And enhanced imaging techniques, for example, dye spray chromoendoscopy, has also been used to help in terms of visualization of these lesions. So as you look here, you can see that there is some mucosal irregularity that's identified, but the margins are a little bit indistinct. But with the application of dye spray, the ones that can be used includes indigo carmine as well as methylene blue. Once you apply that to the area, the margins of the lesion becomes a little bit more distinct, and you can even inject methylene blue so as to allow for submucosal resection of this endoscopic resection of this lesion. Virtual chromoendoscopy is also recommended using narrowband imaging, and for those who use pentax scopes, then you can use eye scan. And as you can see, there's an obvious lesion that's here, but you're able to visualize the pit pattern of the lesion a little bit more clearly under using eye scan. So notice that for this guideline, standard definition scopes is no longer on this guideline. And at the time of colonoscopy, then targeted and non-targeted biopsies should be performed. And we'll talk about that in a little bit. Previous guidelines had recommended that at the time of surveillance colonoscopy, 4-quadrant biopsies should be performed every 10 centimeters, plus targeted biopsy of any lesion detected. Now, by the time you get to the cecum, in most cases, you have around 70 or 80 centimeters of scopes, so of scope in. So that works out to be over 32, around 32 or 33 biopsies that should be taken. But we know that this particular technique, it visualizes less than 1% of the colonic mucosa. And studies have shown that as clinicians, we don't take enough biopsies. And more recent studies have also confirmed that the yield of random biopsies is quite low. That, coupled with the fact that using high definition scopes, we can actually macroscopically detect over 90% of these lesions. And so the 4-quadrant biopsy method is falling out of favor. But for this current guideline, their recommendation as far as biopsy is concerned includes performing targeted biopsy of any suspicious lesion that's seen or any mucosal abnormality, as well as non-targeted biopsy, which is just taking random biopsies without seeing any suspicious lesion. But it did not state whether or not there should be 4-quadrant biopsies. So it's a little bit uncertain as to whether or not the 4-quadrant biopsies should be performed as far as surveillance is concerned. And then there are staging biopsies as well to determine both micro and macroscopic disease activity and extent. My own practice has been to perform 4-quadrant biopsies, and if there's every 10 centimeters, and if there's any obvious lesion that is seen, then I would apply methylene blue, sort of like a modified chromoendoscopy to better visualize the lesion, to see if the margins, if it's something to be concerned about, if it just needs to be biopsied, or if it's a lesion that needs to be resected. In an attempt to standardize the reporting of whatever lesion that's found, they've also updated the terminology for the description of lesions that are seen. Previously, we used to use terms like dysplasia-associated lesion or masses or an adenoma-like mass, and this used to create a lot of confusion. So those terms now have been removed from the guideline, and the lesions that are seen should be described as being either polypoid, non-polypoid, or whether or not there is invisible dysplasia. Polypoid lesions, they're raised above the mucosa greater than 2.5 millimeters. The pedunculated ones, they're on a stalk, and the flat ones, they can be flat and depressed, or they can just be flat, less than 2.5 millimeters or above the mucosa, or they can be flat and elevated. And invisible dysplasia, you look, you see nothing, you perform random biopsies, but it comes back showing evidence of dysplasia. They're also recommending that we use a pit pattern to describe or to determine whether or not it's a pre-malignant or malignant lesion. Many of us are not comfortable using pit pattern just yet, but that will improve with time. Now, after you have performed a surveillance colonoscopy and there's no evidence of dysplasia, when should the next colonoscopy be repeated? And that's one thing I like about this guideline. It should be repeated every 1 to 5 years. However, there is a role to perform risk stratification so as to individualize the interval. So certain risk factors that you need to look, certain factors that will determine when their next surveillance colonoscopy will be include their risk factor for colon cancer, their current and prior burden for colonic inflammation, if they have a family history of colon cancer, if they have concomitant PSC or a history of paradysplasia on surveillance, and the frequency and quality of other surveillance exams that would have been performed. Now, based on that, their procedure can be done 1 year, 2 to 3 years, or 5 years. Now, I just like to highlight that for the 5-year interval for patients who have proctitis, or for those who have Crohn's colitis with less than a third of the colonic mucosa involved, then their procedure should be done every 5 years. All others, they're usually around 1 to 2 to 3 years. If you perform surveillance colonoscopy and you find a lesion, how will you manage it? Well, management of the lesion will depend on the size, if the margins are clearly demarcated, if there are any features to suggest invasive cancer, and the tools and expertise available to perform complete endoscopic resection. So what they have indicated is that for your smaller lesions, the margins are clear, there are no features of invasive cancer, then they can undergo complete endoscopic resection, and surveillance will continue at a shorter interval as compared to others. But for your larger lesions, which are unable to resect or they have features of cancer, those patients should be referred for surgery. Previously, when we biopsied the patients and they were found to have invisible dysplasia, they used to be recommended for proctocolectomy, but this new guideline actually recommends that they undergo chromoendoscopy, dye spray chromoendoscopy to try and unmask or identify any lesion that might have been missed at just high definition white light endoscopy, and then you would manage them based on whatever is found there. But it is quite clear in terms of managing dysplasia that once it's found, the options to consider is either endoscopic resection or surgery, or for those who have invisible dysplasia, if they need to have the procedure repeated with dye spray chromoendoscopy. And frequent surveillance is also crucial for these patients. Is there anything that we can do to prevent colon cancer in the first place? And that has been an area of high focus, but many of the studies done, including those for 5-ASAs, because previously it was thought that your 5-aminosalicylic acid were actually chemoprotective, but the studies have shown conflicting results, including your newer studies, and so it's not recommended. The same for folic acid, and even though statins have shown some benefit, the data is still quite sparse, and so it has not been recommended as yet as a primary prevention method for IBD-related colorectal cancer. But as stated before, sustained control of inflammation has actually been found to reduce the risk of colorectal cancer. And I like how the guideline put it when it says optimal disease control with medical therapy is imperative to minimizing an individual's lifetime risk of developing colon cancer. And so the take-home points from this talk are that patients with IBD colitis, their risk of colorectal cancer is increased, even though we have seen a decline in the incidence over the years. The main driver behind the development of dysplasia and neoplasia is chronic inflammation, and hence controlling inflammation, complete and sustained control of inflammation is crucial, because remember, episodic episodes of inflammation does increase the risk as well. And colorectal cancer surveillance is essential in patients with IBD. We prefer dye spray chromoendoscopy over high definition scopes. But whatever method you have available, high definition scopes, or even if it's standard definition, it's important that these patients actually undergo surveillance. And I will pause here to take any questions that you may have.
Thank you very much, Dr. Dawkins, for your talk. Do we have any questions that can be posted in the Q&A section, as stated before? Perhaps I can ask a question to begin. Can you perhaps comment on the risk of colorectal cancer with regards to the different treatments available for inflammatory bowel disease, if any of them are more effective in reducing the risk? I know we do have a wide spectrum of medications available, from ASA products all the way to biologics. Have there been any differences in terms of the outcomes in preventing colorectal cancer?
That's an excellent question. And as far as the studies have shown so far, I've already addressed the 5-aminosalicylic acid, that the data have been conflicting as far as that is concerned. Some show benefit, whereas others don't. Thiopurines have also shown some benefit, but the issue with thiopurines is the extracolonic malignancies that's associated with it. So many patients actually do not like using thiopurines because of the side effect profile, other malignancies outside of colorectal cancer, but it has shown benefit as far as chemo prevention is concerned. And the new kid on the block, the biologics, they've been around for a long time. And the studies as far as that is concerned is that the incidence of colorectal cancer in these patients is reduced, but it's not that it's completely gone. So even though you have control of inflammation, surveillance is still important for those who are on your newer agents, like your anti-integrins, now your small molecules. It's too soon. There's no data available on those as yet, as far as chemo prevention is concerned.
Thank you. Do we have any other questions for Dr. Dawkins at this time? All right, I'm not seeing any questions come up at this time. So I'm going to take the opportunity to thank you again, Dr. Dawkins, for giving us this talk today. Really informative, and we are grateful for your contribution.
You're most welcome.
Okay, so it seems as if we have come to the end of our colorectal symposium this year. We have a number of individuals we'd like to thank. We can start with our sponsors. We'd like to thank Basie Pharmaceutical, Abbott, AA Lakees, and Apex Radiology for coming on board this year as sponsors. The Jamaica Cancer Society has spent a lot of effort in trying to put things together, and I know behind the scenes there's a large team at the Cancer Society headed by Dion Thomas and Shirley Brown, who have put this together. I'd like to thank our IT team led by David Miguel for assisting to get the speakers together, get all our talks pre-recorded where necessary, and also to host this event today. Just as a word to note that the talks will be available on YouTube at some point in the coming week or two, and that link will be sent out to all attendees. I'd like to take the opportunity to thank all our speakers. We've all been enriched by the contribution from you. Dr. Murphy, Dr. Thompson, Dr. Carter, Professor Gosh, Dr. Roberts, and Dr. Dawkins. Thank you very much for accepting the invitation from the Cancer Society to present this year. And we wish you all the best in your future endeavors. And finally, we'd like to thank you, the attending audience, for taking the time to join us today. Hopefully the information which we presented enlightened your understanding of colorectal cancer and allows you to make some decisions in the care of your patients. If you're a physician or as an interested individual, it can help you to become empowered to take steps to improve your bowel health generally. So thank you again, and have a good afternoon, and keep safe, everyone.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.